So very good morning to everyone, and I am really honored. Thanks to Dr. Supratik Bhattacharya for giving me this opportunity to host this session. So the obesity and diabetes, you know how much this day by day these are increasing in every age group. So this is a nutrition session, and nutrition should be prioritized not only for the healthcare professionals, but the education is the key to eradicate this problem. Based on the latest data from the Indian Council of Medical Research, ICMR, India B reports the release in early 2026 that India is facing a massive diabetic epidemic, and often we call India as the diabetes capital. So with the combined population of more than 230 million, that is 100 million has crossed diabetes, and 136 million are pre-diabetes, and 1 in 5, that is 20% peoples below 30, they are pre-diabetic. So increase in childhood obesity and also type 2 diabetes are very common in the children. Even 50% cases are not yet been diagnosed. So this is another very, very alarming things. So diabetes educator and the dietitian can play a very crucial role and educating this type of people, because when anybody is being diagnosed with diabetes, there is a very low acceptance among the people that they cannot accept that I am also having diabetes. So this Indian significance, that is also not matching, that we say that though IDA recent guideline has said there is no macronutrient distribution, it should be individualized. It is not fixed for each and everyone, but still we are not meeting the macronutrient distribution, that is 50-55% carbs, and mainly majority of the carbs are from the refined carbohydrate, even the millets used being very, very refined. So I will just, before starting the panel discussion, we have a very, very eminent speakers from Mumbai. So Miss Cheryl Salis, everybody know ma'am, and she need no introduction. So I will highlight few of the important things that Lancet Diabetes and Endocrinology Commission for Type 1 Diabetes, she is being associated. International Society for Pediatric and Adolescent Diabetes, she is being co-authored. She is the director of the core committee and faculty trained at various educational institute, associated and corporate houses, authored patient education booklets, and everybody should know she has her own book, that Diet in Diabetes Simplified. It is a very popular book and available in Amazon also. So, and she has many, many achievements, many awards in her name. So without any delay, we would like to know from Cheryl ma'am that what is the current scenario and how to modify and get rid of this pandemic. Thank you. Thank you, Cheryl.
Thank you so much, Somendu, and as always, lovely meeting all my friends from Kolkata. Kolkata has always been my favorite place, I think, from the beginning. And I'm going to be speaking about the Indian dietary conundrum, which is the high carbohydrate load. I think everybody knows about this issue. As dietitians, we really don't, I don't think we even need a talk on this subject. We always see it in our patients, but I'm going to be just discussing as to what are the issues, what are the recent studies, and I've been a part of some of the recent studies which are undergoing publication at the moment, so I will just share with you that data as well. So we all know the metabolic crisis of India. I think we are the country which is facing a tsunami of diabetes, obesity, and everything, okay? But what is very, very alarming is that we have a very large number. We know that we are second to China in the number of people with diabetes in the world. But what is really alarming is that we have a higher number of people with pre-diabetes. And this is the biggest problem and the concern. And that's why I always tell all dietitians that we are preventive diabetologists. We are preventive cardiologists. And I'll tell you why. Because if you see, 1 in 4 deaths in India are now due to CVD. Nobody dies because of diabetes, but people die because of diabetes complications, and CVD is definitely one of the leading complication of diabetes. Now, we all know that postprandial dysglycemia, in fact, this comes up very soon. And most of our people have postprandial high blood glucose levels, but nobody really knows because nobody is checking their blood glucose. And that is the biggest thing. I think awareness is now building up slowly, but still people are scared. I think people don't want, it's like bad news. Who wants to know bad news? So it's better that ignorance is bliss, and we really don't check our glucose levels. But postprandial dysglycemia, so what we call it as dysglycemia, it refers to abnormal blood glucose elevations occurring after a meal. Now this could happen 2 to 4 hours after the meal. Okay, certain times when we have very high GI foods, you will see that the spike in blood glucose is much higher. And this is something that we need to be concerned about, because this is not only in people with diabetes, but also in people with obesity or with people with pre-diabetes. And this is something that we need to catch early. And I think here we have a big role to play as dietitians, as diabetes educators, because we are going to be seeing people even before a diabetologist sees. And we can actually prevent that tsunami of pre-diabetes. And that is where I feel we have a lot of work to do, because that is like if you look at the signal concept, it's the yellow zone. If we can bring people from that yellow zone into the green zone, and we know today that diabetes remission is possible. Now, there are studies. In fact, this is a very popular study, where actually it showed that the lower the HbA1c, the higher contribution is from your postprandial blood glucose levels. The higher the HbA1c, the contribution is from your fasting glucose levels. But in India, it is very different. So remember, our Indian population is very different to our Western counterparts, and that's why we need our own guidelines. We need everything very different for our Indian population. So in Indians, the PPG remains relatively high across all HbA1c spectrums, and especially very high even after higher HbA1c. So where everywhere else in the world, the higher the HbA1c, more contribution from fasting, lesser from your postprandial, but in India, that's not the case. We have the HbA1c across all spectrums being contributed by your postprandial blood glucose levels as well. Excuse me, can you go outside and speak? Now this is, I think everybody knows about the study. This is the recent ICMR. See, there is a lot of studies. We always quote the START study, which was done in 2014, which was one of the landmark studies which actually told us what Indians ate. Because we always feel that East India, South India, I'm from the south of India, you all are from the east of India, we think we are rice eating people and we may be eating a lot of carbs. But what really came out from that study is that whether you're north, south, east, west, the amount of carbs that we consume is similar, and what they saw was that central India actually eats more carbs. This was the START study, which was done in 2014. Now, this is the recent ICMR India survey, which actually shows that yes, nothing has really changed. The carbs is 63%. Protein is still a matter of concern. I think every conference we talk about protein. Every time we talk about protein. Every influencer is talking about protein. But is it really translating into anything? Not really. We still have a big lacunae in terms of our protein consumption, and also the good quality protein, because the protein sources are also not from the good quality sources. And that is a big concern, and the fat is definitely on the higher side. In fact, what they've seen is, and I speak very often to Dr. Mohan's team, and what we understand is anything more than 27% of calories coming from fat, and anything which is more than around 57% calories coming from carbohydrate actually predisposes your risk to getting cardiovascular disease and all the other complications. And that's why we really need to moderate. One is the fat and definitely the carbohydrate. This is our own study which is now undergoing publication, and we decided to actually look at now after say 12 years, 2014 is when the START study was done, and let's see that after so much of education, so much of empowerment, awareness, has anything really changed? And what we saw is nothing really changed. We still are eating a very high amount. If you see the amount of people with carbohydrate that people with diabetes are eating is much lesser than the non-diabetes population, maybe because they're a little more aware. But what really came out very stark from this is that the amount of refined carb consumption has gone up. What has gone up is also saturated fat, because most of your packaged foods have got saturated fat, and nobody really looks at it. We always debate about ghee, coconut oil, etc., which is used in food, but are we really looking at the packaged ultra processed foods which have got so much of saturated fat? We're not really looking at that, and that is what people are eating, and what we are stopping is ghee and coconut oil. Now, even if you look at the What India Eats report, very clearly it has shown that our cereal consumption is very high, our millet consumption is very high. And that's why if you look at the NI and ICMR guidelines, which were released a while ago, it very clearly stated that 45% of our calories should come from cereals, and out of which around 20 to 30% should come from your millets. Because we have to moderate, and we should look at taking around 15% of calories coming from your beans and pulses. Now, refined carbs and sugar spikes, again, we don't really I need to tell you this, but this is what we see very, very often. People are eating bread, people are eating refined carbs, and it immediately spikes up the blood glucose levels. So what is the big concern? You know, we always talk about, nowadays we have CGM, which is the continuous glucose monitor, and what we are more concerned about is the glycemic variability. Now, what is a glycemic variability? If you look at the CGM trends, you will see that the blood glucose oscillate between a high and low. And you will have a very good HbA1c. HbA1c will be like 4-5%. But if you look at the amount of fluctuations or variations in blood glucose, it goes as high as 400 and it will come as low as around 70. Now remember, this oscillation of high and low, or the mountains and peaks and the troughs, are actually more harmful, and this is a big, big contributor for cardiovascular risk as well as other metabolic conditions. And that is why, even if you look at the CGM reports, I'm sure all of you see CGM reports, what we need to look as dietitians is the glycemic variability. We definitely look at time and range, but the CV% or the glycemic variability should be less than 36. Now, I've given you an example here, it's 40%. This is when the person actually came to us and we were managing to bring it down. So this is something also that we as dietitians need to look is the glycemic variability. And we all know that the complications the glycemic variability can cause. Now, I think again, this audience knows about glycemic index and glycemic load, and these are two important things. Remember, just looking at glycemic index is not enough, because every food will have a particular speed at which it raises the blood glucose levels, but also the amount. And I think what we often quote is the watermelon example, where watermelon has a high glycemic index but has a lower glycemic load. So we need to look at both to complete the entire puzzle. Millets. I think everybody became a militant some years ago, a couple of years ago, because government promoted millets and we had the International Year of Millets and everybody started using millets. And this is from Dr. V. Mohan's study again, where they looked at what are the millets available, you know, in the market. And what they saw is most of the millets available in the market are all your polished millets. And that's why people get surprised to see that if I've eaten ragi, which is supposed to be very, very good for diabetes, why is my blood glucose level spiking? And this is something that we commonly see in our practice as well. And therefore, most of the millets which are popular, whether it is your sorghum, whether it is your pearl millet, maize is not a millet but it's a corn, again commonly eaten, or your finger millet, these all rapidly spike up blood glucose levels. And therefore, we have to look at lower glycemic index millet options which are available. Now, effect of the high GI GLBs, it definitely people eat more. And I think potato, I've just come back from Kathmandu and I saw potato was a part of every meal. Okay, so there was rice and potato, and I think the same thing applies here as well. We love our potatoes, and that is where again, if you see the glycemic load of this meal is very, very high, which actually causes your blood glucose levels to go high. So in the morning when I'm eating aloo puri or luchi aloo, or if I'm eating a roti with aloo, and lunch again I'm going to have your rice and aloo, and what's going to happen? My postprandial blood glucose levels are going to be high. Another thing that we oftenly, at least I remember, and I'm sure Ipshita will agree with me, that when we started our practice, you know, because I think most of us are in that age, I think where 25, 26 years ago, at least when I started, is when we used to tell people eat every 2 hours if you have diabetes. And you know, people used to really eat, and it was like eat carbs, fat is a villain. So breakfast, it used to be carbs. Mid-morning again they will eat, because we've told them eat every 2 hours, so there'll be a packet of biscuits. Then lunch, and then evening again, because that's when the hunger pangs strike, again they're eating. And constantly our patients are in a postprandial phase. I don't think there is any other phase. From the time they wake up, it's constantly high, and this is what we see even in our CGM reports. Nights are very good, because that's when the lips are zipped. But come morning and the blood glucose is constantly on the higher side. This is because, you know, of this. And that's why today we say that you don't really need to eat every 2 hours. It depends on which kind of drug you are on. And in fact, in between eating carbs will actually spike your blood glucose levels. In the past, we used to say eat breakfast like a king, eat lunch like a prince, and dinner like a pauper. Today we say that the king has become so obese and dysglycemic that eat all meals like a pauper. And breakfast, in fact, has to be low GI, low GL. And that's why we're promoting, instead of having most of the sugary cereals which were promoted rampantly, we are now saying eat low glycemic index, low glycemic load, lente carbs, especially at breakfast, because these will keep your blood glucose levels in range through the day. Now, high GI foods, we all know what happens is rapid glucose absorption, sharp PP spikes, chronic hyperglycemia stress, repeated excursions, and metabolic dysfunction. And therefore, postprandial blood glucose levels is a silent culprit. Let me tell you that every time our PP blood glucose levels rise, we're actually increasing our risk for severe risk. So, they say that high PP sugars is directly equivalent to a heart disease. So that is why we really need to keep the blood glucose levels, especially postprandial, under control. Chronic inflammation. Repeated glucose surges activate inflammatory pathways, accelerating endothelial damage and atherosclerosis and oxidative stress. So these are things that we need to keep in mind, and that's why we should not take the PP blood glucose levels lightly. We need to intervene as dietitians to do best what we can do with diet, physical activity, and if it still doesn't come under control, we do have medications, pharmacotherapy, and that is why it calls for a multidisciplinary approach, because sometimes things are beyond our control. Again, time and range, I think CGM is something that everybody knows about. And we are trying to keep the blood glucose level. So basically you have 24 hours in a day. At least 17 hours out of those 24 hours we should be in range. So at least 70% of the time is when our blood glucose levels should be within the target range. Now we have so much of education, but you see that in spite of so much of education, this was one of the studies done where they saw that only 4% of the 2269 patients in the multi-center diabetes care Asia-India trial specifically adhered to the dietary regimen. And this is something that we see. People come, when they're diagnosed, they'll be very, very particular, they'll be very, very careful, adherence is very high, but over a period of time the adherence disappears and comes, you have your Durga Pujo, and then all the sweets will come in, and then we have one festival or the other, and then we keep saying we'll do it later, we don't go to the doctor, and this is what we constantly see. And despite the availability of various treatment options, you see that the 60% of patients with T2DM exhibit suboptimal glycemic control, and this is very, very true. In fact, most of our population is at a very high HbA1c as well as dysglycemia. And therefore, we have to look at achievement and maintenance of time and range. Today HbA1c is a thing of the past. It's good to do, but it's not the only thing. We have to look at time and range. We have to look at glycemic variability. These are very, very important things, because like we say that HbA1c is an average of highs and lows. You can have a very good HbA1c and terrible blood glucose levels. And that's why we suggest, we know that CGM is expensive. Not everybody can afford it, but at least to begin with, if they can put it once, and then maybe after a few months just to see that whatever advice you've given is working. And these are the effective strategies that can actually help. Now we all know that most of our foods have got high glycemic index, whether it's your idli, dosa, poha, etc. Now I'm just giving you an example, and I'll just finish with this one study that we did. This is 160 gram of cooked weight poha. It roughly has around 56 grams of carbohydrate, because nobody eats just one cup. People love it, and it's called by different names. You have chura. In fact, when I went to Kathmandu also, they had, the chura, which was again very popular. The glycemic load of poha, if you see, it is around 74. So if you calculate the glycemic load, it's 41, which is very high. Okay, it is not high, but it is very high. And people think that poha is God's gift to diabetes. Everybody switches to poha if they have diabetes. But we know when we look at the CGM reports, it just spikes up the blood glucose levels. So glycemic index is 74, which is high. Your glycemic load is 41, 2 minutes. So high GI, high GL, and therefore high blood glucose levels. So this is the study that we just published in December to see, because I'm going to discuss strategies when Somendu asks questions, but this is just a study that I wanted to show you, is that we looked at, when we're looking at meal replacement, not everybody wants to replace all their meals and even a full meal. So we looking at partial meal replacement. Instead of doing a complete meal replacement, you do a partial meal replacement where you replace half the poha with a diabetes specific protein supplement. Because otherwise you see that, we're not really able to meet our protein requirements. Not everybody is a non-vegetarian where we can tell them to eat eggs. And then we have so many religious days that, they don't eat non-veg during those days. So again, where is the protein source going to come from? And that is why we looked at a diabetes-specific protein supplement, and we saw, and we put all of them on the CGM. And what was really amazing to see is that the MAGE, which is the mean amplitude of glycemic excursions, came down. The area under the curve also reduced, and the postprandial blood glucose levels were very good, and satiety was very good. And what we were able to achieve is plus 8.8 grams of protein extra just by doing this small replacement. So this could be one of the strategies. I'm sure there are a lot of it, but this is something that we tried and it really worked. We had 42 participants, and it was like, you know, a randomized controlled trial. So we had people, it's a crossover trial, and it worked very well. And what people liked is that they were able to still eat, because you tell them to have only liquid 3 times a day, it's not possible. Even if you and I are told, we will not be able to do it. But this is something which is like a sustainable strategy. We're replacing half the meal and still achieving good postprandial blood glucose levels. So we're looking at from high carb load to balanced nutrition, and today we have our own Indian guidelines, which is the RSSDI, NI and ICMR guidelines, which I was one of the persons spearheading these guidelines. And from taking inputs from the ICMR India study as well as from the iStarch, what we saw is that this is something which is very sustainable. 50 to 55% of calories coming from carbs, 20 to 25% from fat, and around 15 to 20% of protein. So from 12%, at least slowly try and increase it to around 15 to 20%, and then gradually to around 22%. Now this is sustainable, this is also affordable option, and this is something that we can do across the spectrum. And of course we have to look at quality when we are looking at quantity as well. So quality of calories do matter. So navigating the conundrum from structured stepwise approach, we have to audit the meals. I think as dietitians, we always take a thorough dietary recall, weekday, weekend, you know, all the recalls. Substitute foods, talk about options. And we're going to discuss that in the panel discussion. Always ask for monitoring. And I think today having glucose monitors at home, because you know in the past we didn't really have that, it was expensive. But today everybody can afford a glucose monitor. Tell them to check not only their post breakfast, but post lunch and post dinner, maybe a post snack as well. And that is very, very important. And emphasize on activity, and we're going to discuss this as well. So the way forward is definitely to educate, counsel our patients, take out time, and I think we dietitians really take out enough time with our patients, explaining to them why we are telling them what to do. Advocate, you know, be a champion, balanced meal planning. I don't think we really need to go very low on carb, but we have to include the good carbs and moderate carbs. Prescribe, if required, then we are looking at a DSPS or looking at something else which will really help, and collaborate. I think not everything can be achieved by us. If we done everything and still we are not achieving our results, we have to collaborate with the diabetologist, with the endocrinologist to see that we can help this person to achieve good euglycemia throughout. So thank you so much for your patient hearing, and I'll be happy to take questions during the panel. Yeah.
It is really a very fantastic session and explained by ma'am very beautifully. So I will be open for the panel, and I will just introduce the panelist. So panelist slide please. So before I start the panel, I want to say about a very important journal published in 8 October 25, which is called Serial Killer, that is cereals. Excellent summary of our recent ICMR India B diet paper published by Pushpanar, which is very important, and the message given in this paper was, even if we reduce 5% of our carb in our daily diet, we can manage diabetes beautifully. So please, first speaker slide please. So we have a wide range of dietitians and diabetes educators with us, with very senior to the budding dietitians as well. So we will enjoy the panel. Miss Ipshita Chakrabarti is a registered dietitian, she is HOD Dietetics Department of CMRI Hospital. She is the Vice President of IAPN Kolkata chapter as well as EC member. She has completed 14 LLL certificate from ESPEN and also certified from American Academy of Continuous Education. Recently she has received awarded with Sadhana Award for the Lifetime Achievement and twice IAPN award for the excellence. So welcome Ipshita ma'am. Next we have next we have dietitian Anindita Chakrabarti, who she is also having 2 decades of experience. She is a senior consultant dietitian, diabetes educator. She is also completed her lifestyle wellness management from the University of Class, and Recently, she has certified in psychology, Yale University, United States. She is also very much interested in academics. Her area of interest is mainly geriatric, renal, diabetes, and obesity management. She has several clinics in Kolkata, and she is also life member of several organizations. Next, we have Professor Bijoya Bhattacharya. She is the HOD of Food and Nutrition Department of Amity University. She is the chapter secretary of Bengal chapter Poshandhara. She is IAPN Indian chief program officer at IAPN India Metabolic Syndrome and Nutrition Core Group. She has completed her PhD recently, and she has authored and co-authored many books. She has 17 LLL course she has completed. She is awarded with R&D Sadhana Awards in 2026, and she has many awards in her name. So we welcome Bijoya Bhattacharya ma'am. Next, we have dietitian Pallavi Chatterjee. She is the guest lecturer of Nutrition and Dietetics, College of Nursing, RG Medical College and Hospital. She is consulted dietitian as Apollo Clinic, Shurakha Clinic, and Diagnostic. She is also done her diabetes educator. She is certified advanced course for maternal health and child nutrition from Medvarsity, courses in cardio nutrition. She is also very popular in Kolkata, and she has many achievements and 7 publications in her name. Next, we have Sriporna. Sriporna is also MSc diabetes educator. She is working as a consultant dietitian as Apollo Sugar Clinic, Beleghata, Barakpur. She has completed her interns in MRI Salt Lake, and she is certified renal nutritionist, diabetic, and pediatric nutritionist. She has publication on endocrine, GLP-1 receptor agonist, and smoking cessation therapeutic. So welcome, Sriporna. And last, we have dietitian Rimi Banerjee. She is the consultant dietitian. She is practicing for more than 5 years, and she is into pediatric and adult nutrition as well. She is working now as a freelance dietitian specialized in certified diabetes educator, lifestyle educator, and regular providing quality service, certified food safety auditor, supervisor for FOSTAC and FSSI, academic and professional standings, life member of IAPN. So we welcome Rimi on board. So, and obviously Cheryl ma'am, I missed her. So just one chair, can you shift? Acha, okay. So, obviously I will start the session as per the topic. Then I will come to Cheryl. First I will come to Bijoya. So Bijoya, as Cheryl has said, and she has said the context about the diabetes management, about the carbs, about the myths about millets. You can stop this thing. So I want to know about the distribution of the, especially, do you think that this term is relevant or not? Often we find in many prescriptions of the doctor 1200 calorie, 1400 calorie diabetic diet, and how it is different from a balanced diet. Is there any specification for the type 2 diabetes as you think?
Well, very well put question. First of all, congratulations Cheryl for bringing out such relevant and upcoming researches that you have showed us. Well, this diabetic diet that you were saying, nowadays, as we often say that people are living with diabetes, it's a part and part of our life. Now, the moment we categorize them with a no, that you have to go with a diabetic diet, immediately there is a sense of exclusion, that what I cannot eat. But if you really see that even the guidelines laid by the RSSDI that Cheryl has shared, even the American Diabetic Association, they are focusing more on the individualized medical nutrition therapy and not any diabetic diet. The reason being, in the medical nutrition therapy and when it is individualized, we are in an era of precision nutrition, right?
Yes,
so
I want to know that precision nutrition.
So
yes.
when we are talking about the precision nutrition, so it is many of the times, if you really see the nutrigenomic profile, which I believe even Cheryl will also agree, that many people not necessarily would be responding to all type of carbohydrate in a similar way. Some people, even I have many of my patients whom I have seen that even by having a normal vegetable papaya, their glucose was rising. Initially, I got awestruck, like what is the reason could be behind it. But it is about the nutrient, that how their genes are responding, number one. So it is about the precision nutrition, wherein there is a concept of the nutrigenomics and nutrigenetics. Means how my nutrition is affecting the genes and how the genes are affecting the nutrient metabolism.
Very
and
important.
it is about a bio-individuality. So even as per the latest terminology, if we see that yes, it is the, not the diabetic diet, but the medical nutrition therapy with an emphasis on the type of carbohydrate that we are giving. RSSDI has given an Indian guideline, like 50 to 55% of the total calories shall be coming from the carbohydrate.
Yes.
But their focus is on the complex carbohydrate. That what type of carbohydrates we are giving, because these complex carbohydrates, they are not just able to manage the blood glucose level by lowering the GI/GL of the food, but accordingly they are also playing a very crucial role in the GLP-1.
Also, I want to know, before you go to in GLP-1, about the gut dysbiosis and management of diabetes. So when you are seeing your patients, how you see about the gut, or how you counsel your patients about the gut, then I want to know about GLP.
Okay, so talking about this gut, that how we are saying, first of all, the diabetic patients, if they, the people who are living with the diabetes for several years, they anyways have developed a visceral sensitivity. We know that when there is a diabetes, the blood glucose is elevated. During that time, these elevated blood glucose are eventually affecting the neurons. So the neurons are not just of the diabetic food condition that we see, but it is also equally affecting the neurons of the gut. So which is resulting in a visceral sensitivity, the gut sensitivity. Now these people, diabetes, if I am coming to, it's a metabolic disorder with a very high rate of inflammation, right? It's an inflammatory disorder wherein the inflammatory, pro-inflammatory cytokines are elevated, like IL-6, TNF-alpha, they're elevated. And especially if the person is not a lean diabetic, if the person is an obese diabetic, then due to the visceral adiposity, even the resistin would be high, the other adipokines will also be high.
True,
right?
true.
Now
Very
all
true.
these things are leading to a very humongous condition of the inflammation in the body. Now, coming back to the visceral sensitivity, so I just wanted to establish the inflammatory part first. Now coming back to the visceral sensitivity, when there is a visceral sensitivity with a very normal kind of food also, they start responding. Now if a person is having IBS, because most of the people are living with anxiety, stress.
Even not being IBS, even we need to reduce the inflammations. It is actually an inflammatory problem.
That is the primary requirement.
Primary requirement.
Now in the diabetic person, we have to give them complex carbohydrate, but too high fiber, insoluble fiber is further going to trigger IBS. So there would be a provision of leaky gut.
I will come to this question next.
So the inflammation will be elevated. We have to manage the gut by giving the soluble fiber.
Soluble fiber. Yes, I want to know the last question for this panel to you is fiber. How you prioritize the fiber and which type of fiber?
Depending on the patient's condition, first of all, anyways insoluble fibers are very important because they're going to reduce the GI transit. So if the GI transit is reduced, then the glucose absorption will also be reduced, because very slowly it will get saved into the GI system. But having said this, if a person is coming to me with a GI condition as well, then my emphasis or the emphasis goes on with the FODMAP control, and along with that, the soluble fiber, because the soluble fiber not just lower the glycemic index of the food, or the glycemic load of the food, but also it reduces
helps
the glucose spike. It reduces the glucose spike, and that is the reason we suggest oats, the psyllium, then the beta-glucan fiber which is present in oats, psyllium is there, which really helps to bring down. So inflammation has to be reduced. Then the inflammation from the pathogenic microbes that are already there in the gut, which would be releasing their inflammatory markers into our system, the LPS as well into the blood system, will go down. And eventually it can also help our pancreas as well, because the beta cells are often get overloaded, or like often get not overloaded, they get affected due to the inflammation.
Okay, so I will again come to you. I am coming to Ipshita Di. So related to these questions about the carbs, we have decided about the carbs. So nowadays people are very much obsessed about carbs. There are many carbohydrate counting apps. They are counting the carbs. So how much it is important, that is maintaining each and every grams of food, calculating the carbs in the patient diets, or practically how you manage our patients, especially.
Thanks, Somendru, and at the outset I would like to thank Dr. Supratik Bhattacharya for inviting me here. He's not there, but my message should go out to him. That's different, but if I answer your question, quality of carb matters, and that should be the foundation of choosing planning a diet chart, the counseling a patient. Then comes the quantity. Of course, we need to focus on the quality of carbs what we are giving. So depending on the what already Cheryl has said the context, glycemic load, glycemic index, the fiber content of the food. So these all needs to be taken care, and followed by which we need to focus on the quantity which needs to be given. And we need to maintain the quantity for every meal that has to be there. And of course, considering the quality. If I give like
Types of carb. Which types of carb?
Which types of carb and how many needs to be given. Because
Okay.
as again Cheryl was saying about millets, few years back the Indian year, millet of the year, Indian government and WHO announced, and it was followed in our country. So people are thinking that millet helps a lot in reducing, managing diabetes, but that also has carbs. So we need to focus on the type of carbs and the amount has to be given. So foundation stone is the quality of carbs, then followed by the quantity. That is my take.
So, do you think what Bijoy was thinking the same thing, that how do different types of carbs impact on the insulin response and the metabolic health, and can the same amount of carb for the same family, husband and wife, they are eating the same amount, they both are diabetic, so there will be difference, they can eat the same meal?
Of course not, because our body, our genetic predisposition, our metabolic health, our gut microbiome, all
True,
these
gut is also there.
So gut is also very important, because the way carbohydrate is absorbed, digested and absorbed, the way my body is responding towards that particular carbohydrate, what Vijay is saying, like a simple papaya as a vegetable, that is giving rise to the carbs. So CGM is a very, very, again I agree with Cheryl that it's very expensive, not possible for everyone, but at least normal CBG machine, we can keep it at home. I tell my patient, at least the day you are checking it, at least 5 days away, 5 days, like 5 times per day.
5 times in a day.
5 times per day, like fasting, pre-lunch, post-lunch, pre-dinner, post-dinner. These 5 times one must check. And the types of carbs I have eaten during that particular meal, it will give us positive signal that how my body is responding to that. And if CGM is there, easily, in a much better way, it is being displayed that that particular type of carb, how they are responding to my body. So it's not necessary that same type of carb and same amount of carb will give the same response to different persons. It has to be individualized, precision nutrition, individualized, personalized care has to be there.
That is very important message, that just calculating and giving a 1200, 1400, 1600 fixed printout diet chart in any clinic or any OPDs is not at all recommended. So I will come to Cheryl in context with the same questions what she has told, that postprandial blood glucose responses changed in the meal containing the carbs. So what are the strategies, because the fasting is normal, and people used to check the lab report of the lunch only, lunch PPT, but we do not focus on the other PPT what ma'am said about the CVG. So how to blunt this PPs postprandial?
So I think I agree with all the points like which you were saying. In fact, egg is a no carb containing food, but I see a lot of people with type 1 diabetes, and sometimes we see that even egg spikes up glucose.
Okay.
And sometimes they need 6 units of insulin only for the egg also.
Oh,
more. And
very important message.
This is something that we need to do. Poha, we all know spikes glucose in most people, but there are some people who do not show spikes with poha. So that is why we are looking at personalized nutrition. That's why it's individualized care, and looking at the CGM, asking them to keep a food log. We always tell them to, journal what they've eaten, journal their stress levels, journal their activity, because all of that, sometimes just a fight with the spouse or with your boss can spike up your glucose, and you'll wonder whether it is the food which is, because everybody correlates everything with food. That's the first thing. Secondly is when we talk about oats or we talk about other things.
Yes.
The oats is highly polished and processed. And that's why we see a huge spikes even with oats, especially when it's made in porridge form. So that's why we have to tell them to take either steel cut oats or maybe
rolled oats.
Because most of the oats which are available are instant
Are refined, instant.
So these are things again that we need to counsel them about. And like Ipsita rightly said, that people switch to millets and they thought that ragi is a good source of protein. They say
Ragi is having very high GI.
But we know that it is not really a good source of protein. Makhana is a good source of protein, and today you have varieties of makhana, peri makhana, and
it's too much of sodium in that makhana.
Sodium and saturated fat,
Saturated
because it is all fried in palm oil. So that is something that we need to look at. Strategies would be very simple. In fact, I think the food order is a beautiful strategy. In fact, the person who's done the food order study is a very dear friend of mine, Dr. Alpana Shukla, and we're currently doing also a study with her, where just, the order in which you eat food. You start your meal with vegetable and protein and then move on to eating the remaining meal, which actually helps to blunt the post-meal spike. So food plate is one thing where you take half your plate, which should be vegetables. But very important is to say non-starchy vegetables, because potato is also a vegetable. Yam is also a vegetable. Colocasia root is also a vegetable. So we have to define what vegetable means. And then how of course there are a lot of strategies to lower the GI of food.
Even if you just point out about, you have already said that second meal response. Many people,
That's
patients are not aware about the thing.
See, that's another important thing, that what you eat at one meal will not only impact the post-meal blood glucose level of that meal, but also the next meal. So if you're eating a very high GI, GL breakfast, it will not only increase your post-breakfast blood glucose levels, but also your post-lunch blood glucose levels. And that is why every meal has to be low GI, low GL, because we know that we are always in the postprandial state. We have to give them options in between the meals. Because sometimes you see that pre-dinners itself is around 300, 400. Why? Because they've eaten a packet of ragi biscuits.
Yes.
Or, we've told them papaya is good and they've gone and eaten a complete full papaya, which has spiked up their blood glucose levels. And that
Then quantity also matters.
So quantity does matter. So we have to emphasize that when we are talking about fruits, how much fruit?
How much
So
fruit?
whether it's a 10 to 15 gram carb exchange is what we correspond with one fruit. Because fruit sizes are very different. Each fruit will have a different impact. Then we also, I think this is a very ancient Indian wisdom, which we call Shatapavli, which is walking 100 steps after meals. And this was practiced by our ancestors. We no longer do it. We sit, we are watching TV, and then till the serial gets over, we are sitting with our plate in our hand, most of the people. So walking 100 steps, and this is something that we really advocate in GDM, and it works wonders. And we have evidence today.
Even post-meal, you are saying, post-meal work.
Yeah, post-meal. So post-breakfast, because nobody can really work out 1 hour in a day. So even if they can't do that, but do 100 steps after breakfast, or 10 minutes after breakfast, 10 minutes after lunch, 10 minutes in the evening and 10 minutes at dinner, can really work out. Then the soleus, yeah, absolutely. So these are very important, looking at the meal composition.
Yes.
Like we've given guidelines that carbs should be 50 to 55%. But there is no single macronutrient composition. You have to work what suits your person or your patient best and then modify it accordingly. You have to look at many, many factors. Socioeconomic reasons are also one of them that you need to look at. So these are important, strategies that I would say which will really help. And, we have to give satiety. Because if you're going to tell them to eat less, they're going to be still hungry.
Still hungry, yes.
And then they're going to binge. So very important is to add protein and fiber, and we have enough studies. In fact, there's a beautiful paper by Dr. Anup Mishra, which actually says about protein and fat loading before meals. So maybe a handful of nuts before lunch, like almonds or anything which is affordable, or maybe a protein, like an egg or whatever. That itself will help to suppress the ghrelin hormone and also improve the postprandial blood glucose levels.
So protein plays a very crucial role here.
Absolutely.
So as there is a crunch of time, so I will move to the next speaker, that is Anindita. So Anindita, I will, apart from the diet, many people, madam also said about the CGMS monitoring. So now everything is digitalized, AI is there, so people are more dependent on AI. So there are pros and cons of AI. So the two questions, the related questions, because you practice more on sarcopenic patients, that is BCA, and the second is CGMS. So how CGMS helps your patients, or which are the ideal customer for the CGM you think because glucometer is there at home. So what is the requirement of CGMS and the use of the carbohydrate counting apps? How these are helping, or there is any cons or not?
Thank you, Shomendu, and thank you, Shubhradeep sir, because for him I'm here today. And good morning, all. Actually, CGM, our technology is improving day by day. The inventions, why we cannot take that? Because we can get some help from the technology, and it's remarkable result we are getting after using it. Because CGM is so important nowadays, because even the patients, those are traveling also. So once in a year, if I put the CGM, I can educate more scientifically the patient, because they can see their glucose variability. The people can get the knowledge. It's not necessarily dietitian has to realize that glucose variability, because the patients are much more educated rather than the dietitians and the doctors also. So they can understand the glucose variability. I can teach them that where is a hypoglycemia episode for that particular patient. Yeah, the nighttime hypoglycemic episode. And the hyperglycemia also. The sensitivity, it's very, very important for the GDM patient, because the schedule shares also that just oats also, sometimes the spikes glucose, and papaya also. And the patient, I have another patient, GDM, and the 42 years, she's the 42 years, 11 times she miscarriage, and the IVF patient, throughout the pregnancy, I fed that only rice-based products, because if I'm giving the oats, it spikes. If I'm giving the atta, it's also spikes. The whole day, if I say that idli and the rice and the dinner also rice and the pulao or the biryani, she's okay. So this kind of patient is very important. And I told my patient that you can give the anniversary gift, just a CGM, once in a year. You don't have to put it sometimes, all the times. Only one time, and then can highlight that food log. What is the sensitivity, which food is a sensitive food. So that's the reasons. And another patients, a lot of patients are traveling here and there, because they should understand that one cookies or two cookies or the cream cracker biscuit, where the spice is going on. So they can get that education.
Very, very important message due to crunch of time. Yes, you can add. Yes. So, because there are 3 more panelists, so we have some more questions, and I think the next panel speaker has not yet arrived. So, let us discuss just 1 or 2 questions to all the panelists. So oh, sir has already came. Okay, actually I am seeing here Dr. Arindhuti's slide, so I thought the next is she is there. Okay, so next coming to Pallavi, all the things are very much related, as where she ended, that she is giving 3 times rice to the patients, and patient is also having some gut problem. Patient do not want to take wheat product or maybe gluten sensitivity, and we are in West Bengal, people like to have rice. So in context of GI, high GI food, if the patient want to take, what are the strategies to lower the GI of the food?
Thank you, sir, for your question. Good morning to one and all present here. I would like to express my heartfelt thanks to Dr. Shubhratik Bhattacharya for inviting me today. So, sir, your question was how to reduce the GI, right? So, first of all, the cooking technique is very important. Like retrogradation takes place, so we always tell our patients to have cooled rice, not hot rice, and to have some protein in every meal, and have salads and sprouts in order to reduce the GI. So, and another thing, GL is more important than GI.
Now my next question is about to ask you that sometimes we said about the GL of the food. So people like to have watermelon in this hot season, and it is having very high GI.
Yes,
so
but
what?
Since the GL is low, it can be consumed by them.
It can be consumed in moderation. So GI, GL both are very important. Yes. She has highlighted about the retrogradation, that keeping deep in the refrigerator, and next day morning we are consuming the rice. So, and even adding citric acids or like lemon or vinegar can also lower the
chia seeds or flax seeds to fruits, that can also reduce the GI.
Okay, you are trying to say to add the fiber. Okay, Sriporna, I am now coming to a very, very important and pertinent question that is about the chrononutrition. So the timing of the plate and taming the glucose is very, very important. So you are solely practicing diabetes dietitians, and you can see many patients are there. So suppose a young patient walk into your clinic and her blood glucose was normal, but suddenly you see that she is being shifted into night shift. So everything has changed and she is unable to control her blood glucose. So you just highlight what is chrononutrition and how will you manage this, how timing is important or sequencing is important.
Thank you so much, sir, for this fantastic question, and thank you Dr. Gaurav Bhaduria and Dr. Supratik Bhattacharya for inviting me. So chrononutrition is basically body's 24-hour circadian rhythm, and I will explain shortly how the timing of your plate can tame your glucose spike. So let me tell you a story. In my practice, I have seen a lot of type 2 diabetes, insulin resistance and overweight patients, and surprisingly 30 to 35% of them are habit of skipping breakfast and craving in the late night and in the evening and taking high calorie, high GI food in their evening snacks or in their dinner. So there are various studies in this topic. Let me just highlight one of the interesting topic I found in PubMed. The study published in 2022, a 16 years old follow-up cohort study in US shows that men who skip breakfast have 21% higher chances to develop type 2 diabetes compared who are having regular breakfast. This is basically skipping breakfast leads to significantly high calorie intake in the late night or in the late evening. So coming to the mechanism of action of the chrononutrition, how it's work in our body, there are mainly 3 steps. Number 1, in the morning when the sun rises, the retinohypothalamic pathway of the retina activate the suprachiasmatic nucleus of the neurotransmitter and deactivate the paraventricular nucleus. And number 2, this activation of ACN now activates the transcription factor like clock and BMAL1, and those who have their own repressor time and cryptochrome, leading to a strongly self-regulated feedback loop. And with this light cycle and this feedback loop, now express some peroxisome polyperator protein like PPARGC, PNPL3, ST83 and phosphofructokinase, which are responsible for metabolic consequences like glycolysis, gluconeogenesis and leptin metabolism, fatty acid
Very important.
synthesis. Yes.
Very important
So,
point you have highlighted.
And also with this time, the activation of ACN, cortisol level also increase in the daytime, and melatonin decrease in the with the light cycle. And when the time passes, with the feedback action actually occur. So when the night approaches, the suprachiasmatic nucleus deactivated and paraventricular nucleus activation occur, and this leading to the suppression of those peroxisome polyperator gene and decreased level of cortisol and increase in melatonin in the night time occur. So if we don't take the proper food in the right time, then these metabolic consequences, these metabolic genes may also not work with proper way. If we taking the healthy food in the midnight, so the glucose spike will occur because these genes will not express at that time. So I will give 4 practical tips those who are having diabetes or having a night shift. Number 1, front load of your day. That means consuming more than 60% of calorie whenever you are starting your day. And number 2, consider a time restricted eating period
Yes.
of 10 to 12 hours. Like if you are on your night shift, you can consume it from 10 a.m. to 7 p.m. or 11 a.m. to 8 p.m. That means consuming that 60% of calorie within that time. And number 3, that's very important, that respect a food order. So when you are having your breakfast, lunch or dinner thali, try to consume the non-starchy vegetables or fiber first, then the protein, and then the carbohydrate like cereals. And number 4, watch the night cap. If you are on night shift, don't consume any high glycemic or high calorie food at least after 8 p.m. you can take some high protein and high fiber snacks in your night shift. So in conclusion, I would say chrononutrition is a powerful non-pharmacological tool.
Very
It's
important.
not just what you eat, but when you eat, it also matters. And remember that your metabolism has a closing time. Respect the clock to tame the spike. Thank you.
Very, very, very important. Thank you. Very nicely explained with biochemistry and as well as the practical tips. So last question to Rimi, that maybe a 65 years old man coming to your clinic and he is being diabetic for last 15 years but cannot manage his diabetes extremes recently. So doctor has recently put into insulin also. So what are the things you want to know about his why the hypoglycemia is happening, or why the hyperglycemia is happening? Maybe at the midnight he is experiencing hypoglycemia. So how you manage this kind of patients who is a geriatric patient?
So thank you, Shomendu sir, and my sincere thanks to Dr. Supratik Bhattacharya for inviting me here. And it's a humbling experience to share the stage alongside with my mentors. So coming to the question, I would approach the three strategy like 3T. First one is the timing. So to bridge the gap, I will suggest the patient to take some at later part of the dinner, to take some complex carbs with some healthy fats like some yogurt with some seeds or nuts, or some slice of apple with some peanut butter to get the fuel while he sleeps. And the second is tailoring. We must ensure, I will also agree with dietitian Cheryl ma'am and Sriparna, the protein matrix before we eat the carbs. So we must ensure that his meal or lunch should be most of the calorie come from protein, and we should consider that he eats his fiber first, then a good amount of protein.
That is meal sequencing you were saying about.
Yes, yes. So the blood sugar shooting up later. And the third is the timing or tracking. So I will check his insulin dosage.
Types of insulin is very important.
Yes,
in
yes.
which insulin regimen he is the ideal customer for the CGMS
Yes,
and SMBG.
I'd like to say that if possible, I will approach him to take CGM for once in a month or once in a year. And the main thing is the timing or the chrononutrition and the portion. I will ask him to eat slowly and avoid the screen time.
Thank you. Thank you. I will end just a last. Yes, yes, sir. Yes, yes. We are open for the audience question. There is the mic. And before, sir, you can take this mic. And Cheryl, I will end with you about just few tips about GLP-1 after sir said. Okay. Sir, please.
Just one question. Say about chronomedicine, what you said is right. But in real life, at least where I am practicing, we see a lot of IT chrono. So people are working for Samsung, they're working for Microsoft and all. And when I talk to them, they're very clear. We don't mind changing the doctor, but we get up in the night and we sleep in the day. And that's their work profile. You can't help it.
Yes, we cannot
you see
change.
Truck drivers, not just the elite class. The poor class are driving on the night and they're sleeping in the day. How do you handle them? And that's a practical problem. Giving them this kind of thing doesn't work because you have to adjust for their lifestyle. In today's precision medicine, you have to tailor it to their lifestyle, not they don't have to tailor to your protocol. So any suggestions on that?
Anyone? Yes, Bijay, please take the answer.
Especially for the nighttime workers, we know that our body, it works on a circadian system, right? For the night shift workers, automatically, as you have mentioned, sir, although we know that the hormones, it works as per the diurnal variation. But for the people who are in the night time, for them it is the body behaves as a daytime because they are working in the artificial light. And the hormones, they understand the artificial light. So accordingly, although the insulin secretion would be comparatively lower as that of the morning time, but in the morning they are sleeping, and they are sleeping in the dark condition, they are not sleeping in the day condition. So that daylight matters. Yes. Absolutely.
I just want to ask you that would you then modify the drugs as well if they're going to be doing this, if they're not going to be eating in the day and doing, yeah, so maybe we would like, no, we have to. I think
Same way we are customizing during Ramadan. So
it's
the
not a
same way we have to do.
one-size-fits-all. No, I think it's a very, very important point, and I think what the foundation is that they still have to eat healthy, because we know people, especially, they'll eat biryani at around 2 o'clock in the morning because that's what is available. So they still have to follow the healthy eating pattern. We still have to moderate the carbs and give them options in between, like nuts or whatever, which will help. Yeah, and of course, as you know, we have to work in a collaborative manner with you all, where maybe even the medication dose needs to be adjusted, like we would do for Ramadan. Okay.
Even during your session, she has highlighted about the diabetic specific nutritions which are clinically tested, that are high in fiber. So for this kind of patients, you can add in between to reduce the spike, that is the diabetic specific with high protein, fiber rich and low GI and low sodium. These are the things which can be used for this kind of patient. Thank you. Okay, Aritru, please.
To rise the blood sugar, so only the cool rice. I mean, taking out the refrigerator and coming to room temperature and then consume. Hygiene needs to be maintained, obviously. No, in home we can't keep like that temperature, right? Because it's not in a lab, it's in home. So.
But if you are suggesting retrogradation, this should be kept in mind, that how you are doing.
Taking out from the refrigerator. Just as my co-panelists mentioned regarding the meal sequencing, timing, portion control, all these needs to be kept in mind.
Yes, sir. You can add. The mic, please.
Anything apart from it, what we do, we need to publish.
Thing. So one is definitely that, but again when we're heating the rice, people will heat it, and you heat it at high temperature, again the retrogradation will, the resistance starch will break down, because that is something we need to tell our patients about. And so that's why even if you look at the studies, they did keep it at this temperature. It was kept for around 12 to 24 hours, and then what we tell people is raat ko karo, and then that is not actually going to really make a big difference. So I think we can definitely talk about it, but the more important thing is meal composition, food order, which are more practical options, and also something which is not going to increase the other load. I can't see you actually. Absolutely. It has to, because that is what the studies were
So
done.
I have to wind up this session here. The diet and nutrition is so interesting topic, so it will go on and on. And there are beautiful panelists. So you please take the question at the in the audience or in the tea break. Thank you, thank you. So we can invite the next speaker. Thank you.
Thank you, sir, and thank you to the entire panel for the wonderful discussion this morning. So we would move to the next part of the session, that is AI Symposium, covering biostatistics with AI by Dr. Alok Modi, who is actually leader of AI research, medical research in India. He has many accolades with him. He is a board certified American Board of Artificial Intelligence and Massachusetts University in Artificial Intelligence. And with this, I would hand over the speaker the mic.
So this is my disclaimer. Whatever I'm talking here has got no financial gains from whatever AI tools that I'm using for this presentation. These are some of the AI tools that I use regularly for my presentations, and this is what you're going to be seeing. So I'm going to talk about something very interesting here. That is, I'm going to talk about biostatistics, which you use for artificial intelligence, which you use for biostatistics. Now, a lot of us keep discussing about statistics being done. You collect your data through prospective, retrospective study, and you do RCTs. And we generally use SPSS and conventional softwares. So what's so great about it? So there are something which AI does and which is something wonderful, and that is something we're going to discuss here. There are quantitative methods, there are core functions, there are applications, there are some things which are there in AI which gives a huge difference when you're doing biostatistics. Now, this is actually very different. Now, if you ask me, and I would prefer this to be a discussion rather than a presentation, because it would make more sense to people who are doing statistics. Conventional statistics, you have to have a sound knowledge of what statistics is all about, and that helps you to figure out how do you interpret your data. Whereas AI, you don't have to have a sound knowledge of statistics. Of course, you need to know what you're doing.
So is it statistically significant or not? Because AI not only tell you that, AI will also tell you what would be the pattern 6 months from now or 1 year from now. So that is like something like a silico analysis, which is not possible with conventional statistics. To give you an example, if you have a data of some 50,000 patients with pre-diabetes, So you can infer that lifestyle changes have responded and have given you decrement of pre-diabetes to a normal level in some 15% of your patient data set. But how many of them will develop stroke? How many of them will convert to type 2 diabetes? And when they will convert is something only AI statistics can tell you, conventional statistics cannot tell you. Another important thing is non-linear prediction. In normal statistical analysis, you can interpret and say as your age advances, BP rises, right? So that's a linear graph. Now, can you compare the advancement of BP with age? Is it different in a South Indian population? Is it different from a North Indian population? Is it different from a Gujarati population? Is it different in a Bengali population? This kind of analysis no statistical tool can give you. This cohort analysis is possible only with AI. I'll give you a very classic example. I was present for the DIPSI meeting last month in Chennai, and I was asked to give a talk on AI prognostic markers and diagnostic markers of GDM. So I did a review of the literature that was mind-boggling. There are meta-analysis of more than 5 lakh to some 10 lakh patients, and there are multiple such meta-analysis. And Shishai sir, who is one of the grandfathers of AI, has also done an AI work. So in classic DIPSI guidelines,
GDM in the first trimester, which has never been heard of. So this is the kind of analysis which an AI can do. It can give you a predictive analysis. To give you a live example, I'll just show you what it means. You can predict a person going into sepsis on ventilatory support in an ICU when he walks into the ICU off ventilator. This has been shown to work in Mayo Clinic. They're using it regularly, and the mortality has dropped by 15% in the top centers of Mayo Clinic. This is the kind of biostatistics which runs on AI. Another important point is it is a live statistics. So a normal statistics works when you have a data of, let's say, 10,000 patients. You have the data, then you work. With AI, as you have 10 patients data, and as you add the data, the statistic keeps running live. And that makes a huge difference in the outcome and predictive analysis. This is possible with AI. So these are some of the advantages of AI. It's a huge topic. I cannot cover it in 10 minutes. Only 3 minutes are remaining. So there's something called as logistic regression. So suppose you have 50,000 MRIs. How do you know how many of them have infarct and how many of them have got a bleed? No statistical analysis can tell you. This yes-no analysis is logistic. If you have a patient with ABC parameters, how many of them will diabetes? Yes, no. This kind of logistic regression only AI can do. Conventional statistics cannot apply. So outcome analysis or predictive analysis in a set of patients as to the clinical decision support system in your ICU, in your diabetes clinic, in your hypertension clinic, in your GDM clinic is possible when you do a live application of AI analysis. So I'll tell you two things about random forest, a very important tool in AI. What is random forest? So let's say ma'am is doing seeing a patient of GDM and she decides this will be the treatment. So she's one tree. Ma'am is here another. She picks up the management strategy on another patient and she decides one outcome. Dr. Bharat is there, he picks up another patient and decides this outcome. Now suppose you have 50,000 such people. So all these trees become a forest, it's a random forest. You take an analysis of all of them and you come out with an idea how you should be managing it in Kolkata. Can you imagine what would be the outcome? So you can do a live random forest analysis, works that way. This is random forest analysis. You combine the predictions of everybody and you can create guidelines live on the move. Now what happens is her analysis is taken. It may have some defects and some right thing. She modifies it. He modifies it. The 50,000 person modifies it to the fine-tunest level. And that is called extreme random forest analysis or XAMBL. And that is called gradient boosting. That comes out with the best clinical decision support system. And that has changed the outcome of mortalities and morbidities of outcomes in a huge way. This is how AI biostatistics works in real life. This is something mind-boggling and it is very much a truth. And am I talking through my head? No, I'm not talking through my head. I'll give you 3 live examples from the literature. Now this is another thing. When a statistician gives you an analysis, you say this is my analysis. You have to accept it at face value. And the reality is the statistician doesn't know what clinical medicine you're doing. You don't know what he's doing. And both of you somehow join hands and publish a paper. Now in real life, it is very difficult to understand this. Whereas in AI, when you apply SHAP, or when you apply ensemble learning, it is called explainable AI. It can actually walk you through the analytic process and tell you where things have gone wrong and where things are right. So I'll give you one example of this, 378,000 patients from UK, where the comparison was done to the ACC and AHA guidelines, and they found that the area under the curve was much more than the classic ACC curve. So you can see it is 7.64, 0.764 versus 0.728, and that changed the whole outcome of the data, and the guidelines and the position statement that comes out is going to be very different. Another classic example, you can see the references in liver cancer prediction. Here in the Michigan cohort of 442 patients, they took up different cases and they applied two different statistical analysis. They applied the HALT-C model, they applied the Michigan regression, and then they compared it to the machine learning model regression, and they found that the area under the curve was much superior with machine learning, and this took into account different kinds of cirrhosis. Now, how do you differentiate different kinds of cirrhosis and come out with hepatocellular carcinoma? This cohort analysis was possible through AI, and the outcome was huge. So you see, the future is very different. As and when you start working with AI, your own patients in your own clinic, your own area, your own district, your own state will come out with different guidelines which have never existed, and the healthcare scenario is going to change very drastically. In your own ICUs, in your own hospital, you can predict how many patients will get admitted in the next month, how many will get admitted the next week, and insurance can decide how much expenditure you will be doing on your clinic, your database, and can tailor-made the premium for your hospital and your clinic. So you see, the future is mind-boggling when you apply AI statistics, and this I'm not talking through my head, this is the reality which you're going to see. So if you look at this data, you can see the area under the curve and the various analytics that is there is tremendously high compared to conventional statistics. So since I'm just running short of time, I'm just showing you a snapshot. The final message that is there is the classic statistics is not out. It does not exist. It has got its own limitation that applies for certain data sets. But if you want a live, throbbing, actual real life happening statistics, which modifies itself based upon your requirements and your patient database, which changes on a daily basis. If you want to do research in your own clinic and give superior answers, then the way to go is AI-based biostatistics, and that is where the things go. And if you want to be a part of this, you want to learn more, you can scan this QR code. We are running this Doc Yantra and Shift Foundation. Dr. Bharat Sabu is another co-founder, is here. We have this fantastic discussions on the WhatsApp group QR code which you're seeing over here. You can join them, you can contribute, you can add to the discussion, you can teach us, and we can take these things in a very long way in the future. So thank you very much, Supratik, whom I very fondly call Bade Bhai. Thank you for this opportunity. And I have not done justice with my talk. I really can't cover it in 10 minutes. I just wanted to get you excited and interested. If you really want to put your hands into it, we have done some publications ourselves, and there is a lot of work which can be done. And this work comes at a much cheaper price, in a much faster manner, with a huge data set, and it is something which can be modified depending on the variables of your patient, and it can take into account qualitative variables and quantitative variables and much more variable data set which you can't. To summarize, just give you one statement. When you listen to the Indian Meteorological Department, which it says it's going to rain tomorrow, you know it never rains tomorrow. When it says it doesn't rain, you know you get wet tomorrow. Same thing happens with AI statistics. It predicts with variables which are unmatchable and gives you outcomes which are again unmatchable. Thank you very much for the opportunity. I'll move on.
So, sorry for this glitch. I want to talk about in next 12-15 minutes or so about agentic AI and how it can transform the key practice areas. I cannot cover the topic fully, but I will try to show you a glimpse, that because we are moving from AI that answers questions to AI that solves problems autonomously, because AI will take a shape in future where you may not be directly in the loop, but you will be a surveyor or supervisor for it. When we talk about the current clinical burden, 80% of the time is spent on documentation, EHR, we all know this. So there is a data tsunami with advent of CGM, more and more touch points are there, fragmented follow-ups are there, inertia in medicine initiation and escalation of doses is there, complexity are there due to ever emerging new diseases and comorbidities. So the AI landscape is moving from predictive model to autonomous agent, and this is what agentic AI is all about. So we had predictive AI, then came generative AI, which we commonly know as ChatGPT, and then came the agentic AI, which is autonomous reasoning and action. Now what is actually agentic AI? An AI agent is a system that uses a large language model as its brain to plan, reason, act, just by using tools which you use in your day-to-day clinical practice, and learn and retain the memory for a longer term use for the same patient again and again. This is the basic difference between traditional AI, generative AI and agentic AI, because The autonomy is not there in traditional AI. It is medium autonomy in generative AI, but with the agentic AI, it is a high autonomy. It is proactive most of the times. And it is goal driven. So there is a goal with the agent which it tries to fulfill. Now again, the anatomy of a clinical agent, when we see, agent doesn't just talk about the A1C as far as diabetes. It actually fetches the history, analyze the CGM, draft the insulin titration, and then see how it can reach the goal with the patient. What are the key practice areas which can transform the daily clinical workflow? First is OPD workflow optimization. So pre-visit agent can review patient data, transcribe and extract the ICD-10 codes autonomously. It can draft referral letters and patient instructions in an autonomous manner. Smart triaging and follow-up, the agent prioritizes message, flags urgent ketone, general diet query, automatic outreach for no-show patient, symptom checking before the clinician sees the message. So this is something would be very handy. Automated CGM interpretation. CGM gives you reading, but it goes beyond that, and it captures what is not there in the CGM in a proactive manner. So it can give actionable insights, and auto-reporting of CGM summaries can be done. Personalized treatment support with comorbidity checker, dosing simulation, and insurance approval with agent is possible. The agents are doing it. Diet and lifestyle coaching, the multimodal input, patient photos of Indian thali, it can analyze the carbs which we see commonly, but there is a dynamic adjustment to it. In the agentic model, the agent notices a weekend spike and adjusts the Saturday tips so that it can plan your food meal log in advance to the day when you are eating it. Again, closing the loop, the agent monitors fasting glucose daily, alerts the patient doctor when titration criteria are met according to protocol. It safeguards from hypoglycemia, and it is scalable. One clinician can manage 5 times more titration with the agent. Agent can titrate themselves. Then there is 40% improvement in therapy persistence. Interactive education, because the patient can answer ask the question, and agent can answer automatically on doctor's behalf. It can act as a refill agent because it can give proactive reminders about the pill refill, pharmacy coordination can be done, auto order can be placed, and this is how it can benefit you. Now again, remote monitoring, virtual hybrid clinic is a perfect example. Sorry again. Now again, the medication titration support, it can be done with this. Then patient engagement and adherence improves, remote monitoring can be done, research and documentation can be done, data can be extracted, matching patient to ongoing trials. You just check your slide whether they are moving. The real world scenario, how the use case are there in the real world. We have few which were developed by ourselves, so I will try to show you that. The case one is of complex type 2 diabetes patient, and when you see, we presented this at ADA, it was awarded by ADA, the Mitra model, the Mitra Speaks Patient Act, transforming diabetes care with AI powered support. And this we presented at the European Society of Endocrinology, where it showed that transforming patient care through AI driven chatbot technology is possible. So it was previously a chatbot only, then we developed it further, we made it an agent. Again, moving forward, this was in ADA last year, we were fortunate enough to win an award for this, and this actually had a system usability scale of 82 and 95% understood the recommendation which was given by Mitra model. It was surpassing the diabetes educators at that point of time. Now we are scaling it up further, and the study objectives previously were to see that AI tool can be successfully integrated into routine diabetes care workflows, and does it actually improve self-care behaviors and diabetes literacy. And we were startled to see that it actually does. It improves the outcomes and knowledge, treatment adherence and satisfaction, all the parameters. It has a high level of interaction because patient can interact anytime. Again, significant improvement in patient literacy as far as disease education is concerned. 71% reported improved adherence. The features were lifestyle diet tips and CGM interpretation support. That was truncated in 2025. Now we have escalated it further. We have augmented it. We are not replacing clinicians, but we are augmenting it where it can act as an assistant to a clinician, and it can solve non-complex things. It is easy to use, and now again we have 2 data sets which I am going to present at ADA. You are most welcome to come and join to see its impact on type 1 diabetes and type 2 diabetes as far as the agentic part is concerned, because we have transcended it. Now, this is again one tool, CGM Maestro, which is developed by us, and my dear friend Harsh is the pioneer behind it. We all have validated this. Now, again, this is giving trends like predicting hypoglycemia before it occurs, somewhere around 10 hours before it is occurring, by the analyzing past trends of CGM. Now, again, there is one more thing, which is AI role in drug interaction and contraindication. Dr. Alok Bhai is here. He is the man behind this idea, and we are trying to incorporate this into EMR so that any wrong prescription can be prevented. God forbid there are two molecules which are interacting, what can it result and what warnings to be printed. So the agent will work automatically, and then it can relay message to patient automatically that at what time they need to check for what signs and symptoms, God forbid if any complication occurs. Now again, we need to, in a future roadmap, we need to move from reactive to proactive. We need to move to the predictive analytics and IoT integration, because unless we integrate all the data sets which are around us, it doesn't make any sense. This would be a typical day in clinic with the agentic AI. The agent will start the day with priority list, and agent will manage 50 plus remote CGM alert, messaging only 3 critical cases, and you are saved from seeing the 47 alerts which are managed by themselves. This is the workflow, how it will work. The value proposition is 30% almost increase in productivity of a doctor. Now again, there are risks. Hallucination risk is definitely there. Agent making up medication names or doses. Clinician skipping human in the loop validation. They can, I think you are angry with me. So algorithms favoring specific demographics, and then EHR API connection issues can be there. DPDP Act is in India. We need to comply that before doing anything. Transparency should be there and accountability should be there. What is the implementation roadmap? Pilot ambient scribing, then automate follow-up messaging, integrate CGM dataset, and full autonomous triage should be there. What is the future outlook? In next 4 years, we are planning to have a multi-agent orchestration where we can incorporate all the agents together, and we can create an ecosystem with a variable integration also. And we will try to incorporate this into the universal health ID so that all the data set would be uniquely mapped to your unique health ID, and the data set would be flowing across to all the clinics in the same time. So key takeaways are agentic AI is about action. It is not just about text or chat GPT. The physician shift from data gatherer to strategy architect where they can devise their strategy. And we should start small initially. We should optimize our documentation first because it takes up most of our time. So we should start with documentation. From this, from digital assistant to clinical partners, where I see agentic AIs to be heading. And with this, I see the era of augmented diabetologist has arrived. With this, I thank you all for the patient listening. Thank you.
Put up my slides, please. Thank you. No problem. It's okay. It's okay. I think the audience, everybody here knows me, so there is no introduction. Acha, this can be done away with. Let's go to the context. Everybody is here and they want to learn some AI, so let's really learn some AI. Okay. Slides. Yeah. Thanks. Okay, so I don't know, Supratik wanted me to tell doctors, I think we have more nutritionists here, that how you can write prompts. Now see, the most important thing is all of us are using ChatGPT. You're also using sometimes Perplexity, Claude. You're also using Gemini on your mobile phones. So everywhere we sometimes understand what to do, but sometimes we get frustrated because we don't understand that there is a structure in which you can interact with the AI ecosystem. So I'll make it very, very simple, very, very easy to understand for all of you. We do extensive workshops, training contents for the doctors, but let's make it very simple, kind of a guideline how you can talk to the AI ecosystem. And trust me, if you're able to master this art, you're actually going to become a smart clinician or a smart nutritionist, at par with anybody else because it's a very good assistant. You can use AI for answering and getting any kind of a queries as a very good assistant. So look at it as an assistant tool and not as a competitive tool. Okay, so the first thing is, you have all seen that sometimes it's the same model, same question, but there are two different types of answers, right? So why does that happen? Because you have to frame the question or the research question in the right way. And this is what makes it the answers or the output that you get in a different way. So it's a teachable skill. There is the domain is called prompt engineering. So prompting means giving the instruction. The instruction that we give to the artificial intelligence ecosystem, which is your ChatGPT, Perplexity, that is called prompting. And it's an art, but it's also a science. And the science is called as prompt engineering. So let's look deeper. So what exactly is a prompt? Prompt is an instruction that you're giving. It is a textual input because artificial intelligence tools have multimodal, means it can do audio, it can do video, it can do image, it can also do text. So it's a textual instruction which you're giving to the large language model so that it is able to generate a response to you. So there are various ways in which you can structure your prompt. So first, you can see here, the first important anatomy of the prompt is to give it a role, that what it should behave like. So you can say you are a consultant endocrinologist or you are a nutritionist. Then give it a context, on which context it's going to prompt. Give it a task, tell about a format in which you want the output. So whether you want it in the form of a table, whether you want it in the form of bullet formats, and also tell from where it should get the research. So suppose you're searching for a medical article or you're searching for a medical question, you have to say where it is going to look at. So you can ask it to look at only PubMed database, obviously the freely available PubMed database. Or you can ask it to look at only a guideline from a particular organization like the ESD guideline or the ADA guideline. So like that, be very specific about what you want to ask. Now prompting matters because the better you prompt, the better you will be getting the output, which will be a good assistant. So remember, artificial intelligence is like a writing assistant. It's not a truth engine. Now most people mix this. Google and ChatGPT is not a truth engine. It can give you two responses to the same question. It just depends on how you're framing the question, because the AI ecosystem doesn't look at the question as a question. It looks at the question as a flow of algorithm. And if you're able to give the instruction in the right algorithm, the output is going to be in an accurate manner. So what are the tools which we normally use? You use ChatGPT, you use Gemini, you use Claude, and we use Perplexity. See, each of it has its own merits and demerits, advantages and disadvantages. I have just highlighted some of the strengths and weaknesses of each of these tools. You can take a snapshot, and mostly all of us are using ChatGPT because it's easy to use, but Gemini at the moment 3.1 Pro is also very good. It's there on your mobile phones also, and you can all use it. For pro adverse, users like us, in Doctors AI we use Claude, we use Perplexity because it gives you a lot of models and a lot of coding strengths also it gives us. So mostly when you're using it for education, use ChatGPT. That's usually where you will get more work. If you're doing for literature search, try to use Perplexity. Perplexity uses sonar model. If you're trying to analyze images, for example, radiology images, ECG images, now patients are uploading their reports in ChatGPT, right? Try to use Gemini for that. Gemini is good for image analytics. If you're trying to do research work in a very hardcore way, try to use Claude. That's where it works better. Perplexity is like a cocktail model. So it mixes up multiple models and chooses the model based on the instruction that you're giving. So this is how you can choose a large language model for the type of work that you're doing. Now, how do you prompt? So these are the 21 levers you can pull in any clinical prompt. Don't have to memorize this, but out of which we'll pick up some of the most important points. You can take a snapshot of this because every prompt has to have a tone, a format, a role, objective, context, scope, keywords, limitation. But not everything will be required, but some of the important points you need to take up. Like for example, the role, context, task, format, audience and citations. These are some of the format that you have to pick up. Okay, let's make it now very, very simple. First, when you give a prompt, try to give a role, tell what it should do, act as. So you can say you are a consultant endocrinologist with 20 years of experience in type 2 diabetes management. So right, you're asking it to think like an endocrinologist. Then tell the specific task. Build a treatment plan for a 50-year-old male patient with type 2 diabetes, hypertension, with having an eGFR of 55. So you give a very specific task, just like you would ask your intern to do that. And ask in which format it should give it back. So give the instruction in which format you want it back. So the RTF is one of the very commonest used mnemonic for writing a prompt. So you give it a role, you give it a task, and you give it a format. Okay, so this is one of the simplest ways. So for those of you who are very new to using AI or getting just started with AIs, just use the RTF formula. It usually works. Then there's another formula which we call as TAG. TAG is task, action, and goal. So you first give the task, then you specify exactly what action it should do, and you give that, tell it what it is goal. So take an example of the prompt which I have given on the left. The task is analyze the latest evidence on the once weekly insulin icodec versus basal insulin in adults with type 2 diabetes. So that is the task. Now how it is going to do, that is the instruction you are giving. So you tell it to summarize the trials, compare the HbA1c reduction points, and highlights any recent guideline coming out of PubMed. What is my ultimate goal? You give it that equip a busy diabetologist to update their clinical protocol in under 5 minutes. So accordingly it is going to give you the output. So be very specific in a structured way what kind of output you want, and trust me, it acts like a very, very smart assistant, kind of in today's world, making even I would say an intern or a young doctor uses these tools very actively. They can even perform clinical work as at par of a senior clinician. That's the advantage of artificial intelligence. Then there is another way you can do, that's called RISE, which is called role, input, steps, and expectation. So this is another format in which you can give the instructions. So these are just very, very specific structures in which you can write the instruction to the artificial intelligence tool. Also, now this is a little bit difficult for most of us to do, but when you're writing a longer prompt, try to give these parentheses. Okay, so for example, if it's a patient scenario, put it in quotations. If you want placeholders which are variables, then you have to put it in these boxes. If you're giving an instruction, in box brackets, and so on and so forth. So this is actually the concept of text is written in the Word file. There's a context called Markdown format. So this comes from the Markdown format. It's a technological format. Now, what is a weak prompt and what is a strong prompt? See, what is the treatment for diabetes? If this kind of question is a weak prompt, you don't write this kind of a question. You give it very specific question. You're a consultant diabetologist. This is my patient scenario. Help extrapolate from the guidelines of RSSDI and tell me what should be my next step. Okay, so this is how you make the prompt more effective. There are various types of prompts. Again, this is not for doctors to know, not really, but you just might want to know for your interest. There are different types of prompts, like a zero-shot prompting, where you just ask directly without any example. There is a few shots prompting, where you give an example. So if this is this, then now if I'm giving you this kind of a question, try to give me a similar output. So this is the kind of a few shot prompting. Another type of instruction that we give is a chain of thought reasoning, where you don't give the instruction at a whole. You tell it to work in a stepwise manner and give the output in a stepwise manner. So as a result, there is no black boxing. The output comes in a very structured, stepwise manner. There are other types like self-consistency, generated knowledge, and meta-prompting, which are used mostly by coders these days. Okay, so for example, if you have a medical article, one of the easiest ways you can just use an AI tool to summarize it, and you can ask how you want it to be summarized, right? Give the title, give the first two authors, so in which format you want this to be summarized. Again, differential diagnosis is something which we've all been doing in clinics, right? And if you have a good language model tool beside you, you can actually use it for getting a differential diagnosis in your clinical practice. And this is where actually AI comes into use. Dr. Himanish was just asking me, how do people really start using it in their day-to-day practice? What I do is always keep a language model open, and we can always chat. But remember, you don't give the direct patient details. You give the case scenario, and it can always give you a very good explanation coming out of it, right? So these are the examples of a patient-facing content where you can have a controlled level reading going on, and you can give that in the same format of RTF or a tag. You can give the instructions. Okay. Again, when you're looking at perplexity, you can use it for doing PubMed research. This is something that you all should do. I think some of the nutritionists here who have been our students, they've been also doing a lot of research. So you can actually use Perplexity as an academic medical literature search review. So this is a very, very useful tool, and you can use it. So again, you can give this kind of prompts. I'm not reading the prompts. You can keep snapshots, and you can go back and you can read, and you can understand how these instructions can be given to the ecosystem. Similarly, you can use Gemini or DALL-E in ChatGPT for giving a prompt for creating images. We are all using image generators. So these are the kind of examples you can create. When you want to create a very good graphic images, you can give this kind of a prompt. Okay, quickly moving on. So always remember that your first prompt is not the final prompt. So never ever give one single prompt and satisfied with the answer. Your first prompt is the draft. So first you give a request. Even if you don't write please to ChatGPT, although most of us write please give me this answer, it'll still give you the answer. Review what has been given, refine on it, and then reuse it. So there is an iterative refinement. That's how the technology works. So try to do it in that way. And now, of course, we have the agent. I think Dr. Bharat spoke about the agents earlier. So you can use an agent working in an autonomous manner also using these prompts. Through ChatGPT also you can use an agent, or even Claude has also got the agentic architecture workflow. Now, commonest mistake which people make is asking open questions without any role, pasting identifiable patient data. So this is important for all healthcare providers to know. You can use as much as you want for contextualizing and getting outputs from the LLM, but please do not put patient's particular details or demographic details into the GPT, because that is against the DPDP Act. So kindly don't do that. Trusting the first answer. Always iteratively grill it before you get the final answer. Do not accept uncited claims. I'll just take 2 more minutes. And letting the model invent the drugs or doses. So do not let them do that. Reusing prompts built blindly across models. So please remember this, a prompt which is very effective in GPT may not be effective in Claude, and vice versa. Because each of these transformer architecture have their own algorithm. And as I said, technology doesn't understand the way we understand conversation with each other. They understand it in the form of an algorithm. Just be a little careful about the privacy part and accountability part. That is something to keep in mind. Okay, so these are some quick prompts you can take back home. Like you can just take a snapshot. I just kept these so that you can later on, everybody wants to know how to prompt. So I thought this would be useful to all of you. And in each use cases, you can put similar kind of prompts. 5 things to remember. Prompting is actually new history taking for doctors and nutritionists. Match the model to the task. Okay, do not blindly start on a model. Try to use with the simplest framework like an RTF framework or a TAG framework or a RISE framework, and start repeatedly using it and iterate it. Iterating means repeatedly asking the same question and trying to get different types of answer and then choosing the best answer, because please remember it's not a truth engine. It's only a writing assistant. Okay, so thank you so much. I will invite all of you if you are interested, because see, AI cannot be taught in metabolic medicine conferences, to be very honest. So we have a dedicated event. We'll be doing this in New Delhi in September, the Doctors AI Global Summit. Already 150 doctors have registered for this event. So if this interests you and you really want to learn AI, not as a technologist, but just to get started and start using it in your day-to-day practice, we'll invite you all to register and join this event. Thank you so much.
Thank you, sir, for the eye-openers. Coming on to the next topic, we will cover artificial intelligence in childhood obesity by Dr. Himanesh Roy. Sir is a senior consultant in pediatrics and neonatology in multiple super specialty hospitals all over Calcutta. He is an honorary clinical associate professor of DNB Pediatrics in Neotia Bhagirathi Women's and Children Hospital, Kolkata. Over to you, sir.
To change for a slide.
Hello. Hello. Good morning to all. So today I will discuss the topic, very interesting topic, that is the artificial intelligence in childhood obesity. So first thing, you are a practicing consultant or practicing dietitian, you all know how difficult it is to deal with a child with obesity. What is the difficulty? So जब भी एक बच्चे को लेके आता है पेरेंट्स आपके क्लिनिक में, आप अगर बोलोगे जी आपका बच्चा मोटा है, बहुत गुस्सा होता है, बिकॉज दे वांट एवरी इंडियन फैमिली वांट्स ए गोलूमोलू चाइल्ड, है ना? इज इट ट्रू? यस, हेल्दी चाइल्ड इज गोलूमोलू चाइल्ड. सो आप बोलोगे आपका चाइल्ड बहुत मोटा है, वी हैव टू रिड्यूस द वेट, तो वो क्या बोलेगा, आप नजर क्यों दे रहे हो डॉक्टर साहब, ठीक है? सो दे विल नेवर कम बैक टू यू. ओके, सो दिस इज द बिगेस्ट चैलेंज वी फेस in the pediatric clinic while dealing with a doctor. We are dealing with a fat child. So let's see how the AI can solve this problem of this acceptance, this all things related to pediatric obesity. So really this is a global problem because 340 million of children and adolescents affected worldwide. It is increasing, that is quadrupled in last 25 or 35 years, and lot of billions of dollars or pounds are cost are attributed to the obesity. So in pediatrics we follow this live course AI approach, that is starting from the neonatal period, and even before the child is born we can follow this protocol, that is neonatal period, growth trajectory analysis, risk factor identification, early childhood dietary habit formation, active pattern tracking, school age, behavioral interactions, educational program, and adolescent lifestyle coaching, long-term health planning. So these are the things we will follow, and AI will help in this making approach. So early growth monitoring revolution, AI powered growth analysis, real time BMI trajectory projections, because the BMI is very important while dealing a child with whether the child is obesity, undernourished or malnourished. So this BMI can be done or trajectory by real time BMI trajectory predictions, automated percentile calculations, early warning alerts for abnormal patterns, integration with electronic health records. Even in the neonatal period, by these AI algorithms or apps, we can detect that the child will be a obese child in the future. So this is the predicting obesity risks. We can predict it with the AI apps, genetic markers, birth metrics, family history, environmental factors. All these data can be used to predict whether the child will be a obese child in the future. Smart dietary analysis, this is very important, as all the dietitians know that there are a lot of apps nowadays and they are guided by the renowned dietitians. So image recognition with the diet portion image recognition, instant food identification and portion size estimation, nutrition analysis, real-time calories and micronutrient calculations, and personalized feedback, age-appropriate recommendations and parent guidelines. Personalized nutrition plans, AI-driven customization, because nowadays this is a precision medicine era and precision nutrition era. So by this help of the AI apps, we can do this precision by age and development, activity assessment, health conditions, and cultural preferences. By all this data, we can predict and we can do precision dietary modification to the child. This is a very new and interesting thing, that is gamified physical activity. We'll go to the details just in few slides. Understanding behavioral pattern, that is emotional triggers, social influences, screen time balance, and sleep quality. These four things are very important in predicting the trajectory AI obesity. School-based AI integration, that is also a very important thing, that is transforming school and educational environment, because nowadays the school start from the 7 a.m. and till 4 p.m. children are there in the schools. So smart cafeteria system, nowadays lot of schools, modern schools have their own cafeteria. Okay, so smart cafeteria system, automated nutrition analysis of the school meals. So with the help of the recent apps, we can analyze the health of the child, and smart cafeteria system can be delivered. Integrate vending, healthier snacks recommendation based on the individual profile. हर एक को कोल्ड ड्रिंक्स नहीं दिया जाएगा, हर एक को बर्गर नहीं दिया जाएगा. So according to his stature and needs, these things will be vended from the AI with the help of AI. Playground monitoring, active level tracking during break times. ब्रेक टाइम में तो ज़्यादा लोग आजकल मोबाइल देखते हैं, खेलते तो कोई नहीं है, बचपन में हम लोग खेलते थे. So this is all will be monitored in the AI system. Telemedicine, by the telemedicine, the parents will get the guidance from the nutritionists, from the doctors. That is another milestone. Now, this is very interesting. That is called the AI-based virtual VR fitness. Nowadays, what we see that we have all children at our home. आजकल बच्चे लोग खेलते हैं, देखते हैं आप खेलने के लिए सभी क्या करते हैं, मोबाइल टीवी में बिजी रहता है. सो वी कैन इनकॉर्पोरेट दैट थिंग इन द प्रोसेस दैट द चाइल्ड कैन प्ले समथिंग. दिस इज कॉल्ड VR गाइडेड प्लेइंग. सो क्या करेंगे, एक VR सिस्टम को विल इंट्रोड्यूस टू द चाइल्ड एंड उसमें कुछ एक्टिविटी प्ले, जैसे द चाइल्ड इज running and he will get a prize or something. So with that thing we can make the child run at least for some time. Gamified exercise, children becomes the superheroes. They think after wearing the heroes VR, they think we are the superheroes. So we can go and we can run. Okay, we can get that prize. Explores athletics inside VR world, points, rewards and level encourage. So if you run for 10 minutes, you will get some points or rewards. So that start running, at least exercising. Adaptive workouts, AI tailored intensity based on this child fitness level, heart rate. While this child is doing that running or something, there are some smart devices on their hands that can detect the calorie loss, that can detect the heart rate. Okay, that can monitoring the vitals of the child during this workout. So safe environment, because the child is running or playing in the home environment, this is a safe environment. So safety is very guaranteed in this VR environment. VR eliminates the intimidated of gyms, home-based training education, motion sensors, social engagement, multiplayer, because you can play or you can run with all of your best friends. It is called multiplayer VR exercise. Okay, so synchronization with the wearable device. This is also possible. So it builds confidence through non-judgmental environment. Children can play and confidence. We are doing something, and in this process we are losing some weight. So challenges are screen time, because screen time, some parents will tell doctor, you are incorporating that VI, so it will increase the screen time. So we have to balance the screen time and the loss of calories and all the things. So it is a very balancing things. And real world examples like VR dance games like Beat Saber, adventure fitness and sports simulation. These are very important. Sports simulation at your home, as if you are playing a basketball, as you playing a baseball, whatever. So this is very important, and in this process the child loses lot of calories and lot of weight. VR fitness game impact is very well. So 15% reduction of the BMI, 3.2x activity increases, and adherence rate is 87%, because children are interested, what they like, they are doing that. So the adherence is very good with this VR play. Cutting edge research frontiers, that is genomic integration. Now again the precision medicine, that is genomic integration is there. Continuous monitoring is possible with wearable devices. There are a lot of wearable devices that helps in the continuous monitoring. Big data analysis also available. Neuroimaging studies, we do the neuroimaging studies. Microbiome analysis, these are all AI based predictive analysis. Ethical consideration, as Dr. Amit also said, that the data privacy is very important, because your data is your data, it should not be breached. Because in AI system there is always a risk of data breaching, and no parents will ever allow that your data of your child will be breached. So this is an ethical consideration. Health equity challenge, because in the rural versus urban area, because we get that we are in the urban areas, it is very difficult to incorporate in rural areas also, unless the government will support us in this process. Technical implementation barriers, that is algorithm bias risks is there, clinical system integration, long-term validation, procession training, these are all theoretical words. Clinical decision support is very important. AI as healthcare partner enhances clinical judgment. This is very true. Evidence-based recommendation. Now, and precision-based recommendation, not evidence. Previously, this was evidence-based. Nowadays, we get the precision-based. Every child is individual, and as per every child, precision-based dietary or the medicine is prescribed. Workflow optimization, that is very important. Future of healthcare vision, AI lifestyle coaching. Personalized robotic companions for health education. Not only the human, the robots will come, they will also teach the things. Disease prevention, early detection and prediction, and disease prevention, precision intervention, molecular integrated treatment. That they will come in the next 10 years, then not only the medicines, the molecular changes in the obese children will take place, and this will cause a miracle in the next future. Building the healthcare generations. Smarter tools for healthier futures like clinicians, innovators, families, policymakers, this all should be integrated. Then only we can do a smarter things or for our futures. Thank you so much. Any question? First thing, that this type of diabetic medicine or anti-obesity medicines are not at all recommended below years 10, 12 years of age. Okay, still now it is on the research phase. We can't, unfortunately, the pediatricians can't use any medicines like GLP inhibitors and all the things. Only the things can we do, that is the lifestyle modification from the neonatal period or even before the pregnancy starts. Okay, so this is the very important, and the role of AI is here. That we can do this VR. I have just shown you the VR exercise pattern. This is very new things is coming out, because already child is seeing the mobile or TV. We can convert this habit into a good exercise pattern. So unfortunately there is no medicine, only this lifestyle modification. This is very important. And some medicines, the semaglutide or something is on research, but it is not, till now it has not come in the guidelines. Any question? Thank you so much. Thank you.
এটা চলছে না? হ্যাঁ চলছে। Thank you, sir. So, concluding the AI symposium, we will now again move on to the panel discussion, that is thyroid disorders in pregnancy. I would like to invite Dr. Sharmishta Mukherjee, who is HOD Medicine of B.R. Singh Hospital, Kolkata, for the panel discussion. Over to you, ma'am.
So good morning everyone. From the world of artificial intelligence, we are now moving into ground reality, that is thyroid disorders in pregnancy. So all of you know that thyroid disorders are age-old disorders. You already are seeing in the picture that even in the ancient pictures, like the picture of Cleopatra, there is large goiter. And since it is predominantly the disease of the females, naturally pregnancy has great impact on it, and vice versa, that is thyroid disorders has impact on pregnancy, and pregnancy has also some impact on thyroid disorders. So to focus on this very important topic, we have some esteemed panelists today. Among them are Dr. Rupa Sharan Ganguly. Is she present here? Dr. Shivanjini Nayak, both are obstetricians. If you are present here, you please come to the dais. And then Dr. Joita Banerjee, pathologist, Bia Singh Hospital. Dr. Atrey Roy Chaudhary, she is specialist in biochemistry. Dr. Rajiv Mukherjee, he is the practicing physician, and Dr. Kaushambi Basu, who is the pediatrician. So we have a multi-speciality approach to enlighten thyroid disorders in pregnancy. We have, is there any physician or gynecologist who can volunteer, who can replace the Bishajit? Can you please? Okay. Okay, then we will distribute among ourselves because two panelists are not there. So without wasting time, this was actually the question of Dr. Rupa Sharan Ganguly. Why are we so concerned about thyroid disorders in pregnancy? So any of the panelists? Yes. Dr. Atrey.
So, as we all know, many physiological conditions can affect thyroid hormone homeostasis in our body. So, in pregnancy, there is estrogen-mediated increase in TSH, which can cause increase in TSH, and that decreases the renal clearance also, which further elevates the TSH level. And more so, it increases lipogenesis and decreases lipolysis, and as a result there is a chance of hyperlipidemia, and there is also increase in insulin resistance, which can further add to the metabolic syndrome, and all these can in turn lead to more chances of adverse outcome in the neonatal period and as well as in the perinatal period, and also for the mother, going on from here, the child in his life increases the risk of having metabolic syndromes, including thyroid hypothyroidism as well as obesity. So that is why it's very important to identify any presence of hypothyroidism in pregnancy or hyperthyroidism in pregnancy. Also there is chance of thyrotoxicosis for the mother in the postpartum period. So it's very important to diagnose any thyroid disorders in pregnancy very early and treat accordingly. And we also have trimester specific reference ranges to monitor the thyroid
Dr.
status.
Atri, I think that will be described by other panelists later. So both hypothyroidism and hyperthyroidism can lead to various maternal and fetal complications, starting from abortion, from gestational hypertension, abruptio placentae, PPH, to preterm birth, low birth weight, stillbirth, etc., etc. And in hyperthyroidism, all the maternal complications, including the heart failure and thyroid storm during parturition, and fetal complications, both neonatal thyrotoxicosis and hypothyroidism, which we will come to later. Our pediatrician is with us. So my next question is to our physician, Dr. Rajiv Mukherjee. There are a pair of cases. Case 1A, known hypothyroid for 5 years, on L-thyroxine 50, desires pregnancy. Both have come to the physician for planning of pregnancy. First one have already she is hypothyroid and she is on L-thyroxine and her TSH is 5.8. And case 1B is there is no history of hypothyroidism, but the patient is again planning for pregnancy and it is seen that the TSH is 5.8. So what will be your approach to the patient? Is there any difference between the approach of the two? One is non-hypothyroid and another is non-euthyroid before.
Thank you. First of all, both this scenario aspiring pregnancy, and first case is non-hypothyroid, second case is non-hypothyroid. So in first case, the TSH is 5.8, patient is on levothyroxine 50 and desires pregnancy. First of all, we should counsel the patient because we should first approach towards the target value of the TSH in preconceptional target. We should know the preconceptional target of TSH is the target value of TSH that is in first trimester, that is 2.5. So first of all, we should approach to the goal 2.5 TSH, then the patient is being asked to take pregnancy or try for pregnancy. So we should enhance the dose of levothyroxine, suppose enhance by 12.5 or 25 microgram per day actually. And in second case, there is the TSH is 5.8. Most probably she is suffering from subclinical hypothyroid, and in this case, as per international and national guidelines, as per ATA or ITS or FOXI guidelines, we should start levothyroxine also, because it is more than 4 and our target value will be 2.5. In both cases, we should again repeat or recheck TSH after 6 to 8 weeks, and dose adjustment should be there according to that. But we should keep in mind that over treatment is also dangerous for these patients, particularly while patient is being pregnant. That will be covered in later. So in both, we should start levothyroxine, and both the guidelines, international guidelines and national guidelines, are telling regarding that.
So absolutely right. As per guideline, we will increase the dose to 25 to 30% in the first case, and in the second case, another thing is there, we should do one antithyroid antibody, anti-TPO
very
antibody.
Important. I missed it. Anti-TPO thyroid antibody is very important here, but not to start levothyroxine.
No.
Both negative and positive anti-TPO antibody, we should start levothyroxine, but to assess the severity. As we know that anti-TPO antibody, if there is positive anti-TPO antibody, there is chance of increased miscarriage, chance of increased preterm delivery, chance of adverse fetal outcome, and last but not the least, there will be chance of conversion of overt hypothyroid of the patient by 35 to 50% in future. So for future reference, anti-TPO antibody should be done here. I have missed.
Very rightly said. So prognostication is helped by anti-TPO antibody. So my third question is to Dr. Joyita Banerjee, our pathologist. What are the physiological changes observed in thyroid function test during pregnancy? This is very important because sometimes there is diagnostic dilemma versus physiology versus pathology.
Thank you, ma'am. So there are 3 types of physiological changes observed in thyroid function related to thyroid profile in case of pregnancy. First of all, there is increase in human chorionic gonadotropin level of maternal serum. So this is produced mainly by the placenta of the fetus, and it structurally mimics the TSH. Hence, it stimulates thyroid TSH receptor to produce much more T4 and T3. Hence, the level of total T4 and T3 increases, and it in turn produces a negative feedback to the pituitary gland, so that TSH secretion is suppressed. So there is increased level of total T4 and T3. We should remember that T4 only can cross placenta and helps to develop fetal brain. So till 18 to 20 weeks, fetal brain is entirely dependent on maternal thyroid T4 particularly.
Exactly.
So it is very important to maintain this transient thyrotoxicosis to maintain the fetal development, brain development during the pregnancy period. Second is placental estrogen rises, and placental estrogen in case stimulates liver to produce much more thyroid binding globulin, which in case produces much and more T3 and T4 level. And the third is these two things, this HCG and the thyroid binding globulin, they give rise to increased total T3 and T4 level. But hypothyroidism can also occur. This may occur in late of the pregnancy, and it becomes overt if maternal diet is insufficient in iodine, because increased thyroid production needs increased iodine demand. If iodine is sufficient in maternal diet, then it's okay, then sufficient T3 and T4 is generated. But if maternal
and also there is increased iodine clearance in pregnancy because of
iodine,
increased eGFR.
Yes. GFR increases almost 50% in pregnancy, and hence iodine clearance also increases. So iodine clearance increases, and if maternal diet is insufficient in iodine, then what happens? So maternal thyroid, it has to struggle for producing much more T3 and T4, ultimately which can rise to goiter. This is only and only physiological part. But if there is pre-existing maternal autoantibodies, which is pre-existing Hashimoto or Graves disease, so they can worsen this scenario.
Yes, that is very important. And so this abnormal thyroid function test picture, we should not be worried about it, we should not be scared, because most of them are physiological, and we should stick into doing free thyroid hormones in case of pregnancy because of estrogen effect of increased TBG. So total T4 and T3 is often fallacious, and
specific
definitely what you have
ranges.
told about the physiological adaptation of the body to produce more thyroid hormone due to HCG. So my next question, it was actually to Dr. Shivanjani Nayak. She was a gynecologist. May I ask this to Dr. Rajiv Mukherjee, because I think these cases are also dealt by us, our physicians and endocrinologists. So again, a pair of cases. Case 2A, 25-year-old primary gravida, 10 weeks gestation. She is asymptomatic and having T3 and T4 raised. So what we have discussed now is just reflected in this case, and TSH is low. So what will be our diagnosis and management? And case 2B, exactly the same age, same 9 to 10 weeks of gestation, but she is symptomatic. She has persistent vomiting for 2 weeks with palpitations and mild tremulousness, and weight loss of 3 kg despite pregnancy. And her TSH level is also lower than this patient, and free T4 and free T4 is mildly elevated, and TRAB is negative. Beta HCG is markedly elevated. So what is your diagnosis and how will you manage these cases?
Both the cases are of having first trimester, and first case 2A is clearly the normal physiology of pregnancy. So no need to treat the patient. And
absolutely, already discussed.
Yeah. And in case 2B, there is palpitation, mild tremulousness, weight loss, that is in favor of thyrotoxicosis or hyperthyroid. But here is the pinch that beta HCG is markedly elevated and TRAB is negative. So it is clear cut of pregnancy-induced transient thyrotoxicosis, and it is also not any no use of antithyroid agent or antithyroid drug. We may use propranolol like that to control palpitation or tachycardia here for temporary period, but there is no role to treat aggressively here.
Absolutely. So both the cases should be observed. So first case resolves after first trimester, and the second case here also it resolves in 60% by 20 weeks. Similar history may be observed in prior pregnancy or in mother or sister, and usually there is negative ATA. Beta blocker may help. Multiple pregnancy is more prone to this, so it is associated with hyperemesis gravidarum. So now my question is to Dr. Atrey Rai Chaudhuri. What are the assay hazards usually faced in thyroid function test, not only in pregnancy but in general? What are the assay hazards, because this is very important in clinical practice? Can you just briefly summarize?
Yeah, so different assay hazards in AD test can be divided into 3 parts. First is pre-analytical, analytical and post-analytical. Here we are initially focusing on the pre-analytical part. So presence of any heterophile antibody like anti-animal antibody, more specifically HAMA, that is human anti-mouse antibody, can falsely increase or decrease TSH level. Then there may be second is presence of macro TSH, which can falsely increase the TSH concentration because of decreased renal clearance. Again, if there is any dietary supplements like biotin, which is more commonly present in any hair or skin supplements and also in dietary supplements, that can interfere with streptavidin based assays, more so if it is estimated by Alexis, that is Roche platform, but it's less in OCD platforms. Again, if there is any
negative interference in biotin.
Yes. And if there is any dietary intake of heparin, that also can interfere with thyroid assays. Again, if the patient is already taking levothyroxine, so if the sample is collected immediately after intake of the thyroid medicine, then that can seriously interfere with the assay. So we recommend to collect the sample prior to taking medicational dose of that day. Then analytical interferences can be there because of diurnal variation, and post-analytical interferences can be because of wrong estimation and a typographical error, which is very common in all the tests. So these are in summary of the different types of
very nicely said. Actually, I have also thought of these things.
I would like to add one more thing. That one thing is that while I am advising for TSH, it is not fasting one. First of all, according to the latest guidelines, no fasting needed for TSH estimation, but we should do it before 10 a.m. because there is circadian variation of TSH level, and its most level, maximum level is achieved between 7 to 9 a.m. So we should do it before 10 a.m. and no fasting is needed. And another thing is that commonly patient in pregnancy takes iron and calcium supplement that should be taken 3 to 4 hours gap. Also,
this is very important, very important. Iron and calcium, because in most of the patients, they in pregnancy, they are taking iron, from the second trimester onwards, they are taking calcium. So at least there will be a 4 hours gap. This is very important.
Another thing, ma'am, there is a tendency of patient to take PPIs as pantoprazole or omeprazole like that daily basis. That should not be, and if it is to be taken, at least 4 hours gap should be there, because levothyroxine absorbs mainly in acidic medium. So if you take along with antacids or PPIs, it may hamper absorption. So there should be 3 to 4 hours at least gap while taking calcium, iron or PPIs. That's all.
So these are in hook effect, negative effect on TSH, macro TSH already told. So it is the false increase, heterophile antibodies again already mentioned, and drug interference. So many drugs already discussed. So I am omitting this. These are the hook effect and this HAMA. So serial dilution may help, and the anti-HAMA antibody, other techniques, and PEG precipitation in case of macro TSH. So these are the remedies. So coming to, quickly to the to another set of cases, to Dr. Rajiv Mukherjee, another pair, 25-year-old primary gravida, 10 weeks gestation, no past history of thyroid disorder, thyroid profile is TSH 5.2, FT4 normal. Another case, 30-year-old primary gravida, 11 weeks gestation, asymptomatic, thyroid profile is FT4 is normal, same, but TSH is 12. Is there any difference in treatment? How to treat, when to treat, and how to monitor?
In first case, probably the patient is suffering from subclinical hypothyroid again, and there is, as I said earlier, that we should approach towards the cutoff value or target value of TSH 2.5. So we should start levothyroxine here, irrespective of anti-TPO antibody. And in second case, and we should start with 25 or 37.5 like that. And in second case, we don't know whether the patient is non-hypothyroid or first time we are taking this thyroid profile. Whatsoever, the TSH is 12, that is more than 10. So we should treat this aggressively. So we should start levothyroxine if she is not on levothyroxine already by 1.2 to 1.6 microgram per kg of body weight daily basis, generally 50 to 75 microgram. And after 4 to 6 weeks, we should repeat TSH level, and according to that, we should adjust the levothyroxine dose. And our goal will be 2.5 in first trimester. In second trimester, this will be 3, and last trimester around 3.5 like that.
Yes, so there should be a trimester specific goal. Every population has its own trimester specific cutoff, but if you don't have, then what Dr. Mukherjee has already mentioned, that it is 2.5, 3 and 3 or 3 to 3.5. This is the protocol or the norm, and of course we may do anti-TPO antibody in some cases, but usually we always treat the subclinical hypothyroidism even if that level is slightly high, because in these cases we slightly over-treat to decrease the chances of neurocognitive dysfunction in the fetus, and repeat every 4 to 8 weeks till 24 to 32 weeks, and then postpartum. So my case 4 is a Florich case, a 29-year-old woman, G2P1, 10 weeks of gestation. She has palpitation, heat intolerance, excessive sweating and weight loss, no history of excessive vomiting, history of similar symptoms 1 year back, for which she took antithyroid drugs but discontinued. There is tachycardia, diffuse goiter with bruit, and fine tremors of the hand. Eye signs are present as there is lid retraction and mild proptosis. You can see the picture of the patient here. So the diagnosis is written in the face, and the TSH is less than 0.1 milli international unit, that is low. FT4 is high, FT3 is high, and the patient is TRAP positive. TSH receptor antibody is positive. So how will you manage this case? There are certain questions. First question is to physician. What medication, how will you monitor, and what is your target?
The clear-cut diagnosis of Graves' thyrotoxicosis, and here we would start antithyroid drugs, and radioactive iodine therapy is contraindicated here. And as the patient is on first trimester, The drug of choice is PTU, that is propylthiouracil uracil, because methimazole or carbimazole can cause embryopathy in first trimester. So we should start with PTU, and we should continue this PTU up to 16 to 18 weeks, jolly well, and then switch to methimazole or carbimazole. And we should monitor every 2 weeks LT4 level, not TSH level, because it will affect the TSH level after 6 to 8 weeks, but it will affect that LT4 level every 2 weeks. So we should monitor the LT4 level, and it should be normal or mildly high normal. Our target will be there. And after that, we should switch to methimazole, because prolonged use of PTU may cause liver derangement or deranged hepatic function actually. So this is the our target. I again telling it is not TSH, it is LT4. The target should be LT4.
Exactly.
FT4,
So the message which has been conveyed is that the medication should be first trimester, it is propylthiouracil. From second trimester onwards, we should go, preferably we go for methimazole and carbimazole, because of the fact that there is no chance of embryopathy now, but the PTU, the propylthiouracil, they cause idiosyncratic hepatic, both are hepatotoxic, but when there is idiosyncratic hepatic fulminant hepatic failure by PTU, it may even cause death of the patient. So it is preferable to shift to methimazole or carbimazole in the next second and third trimester. Monitoring never by TSH, because TSH, even after control of hyperthyroidism, TSH may remain low for years together. So FT4, and that should be kept in the high normal level, because we don't want to keep the fetus in environment of hypothyroxanemia. So that is our message. So second question I am omitting because there is no gynecologist here. So for a long time actually Dr. Koshamki is sitting silent, so please tell us a little bit details. What complications do you expect in the newborn, and how will you screen for thyroid disorders in newborn?
Good morning everyone. I would just touch upon the fetal surveillance in just 2 points, that we would like to monitor the fetal goiter and the fetal heart rate. That should be monitored during for the fetal surveillance part.
Yes.
And regarding the complications in newborn, this neonatal thyrotoxicosis is not very common, but a very common outcome of Graves' disorder in the mother. So we should always be very pertinent to monitor the baby born to a Graves' mother. The complications we would expect is not right. They don't just start just after birth. They come around at the end of the first week. In fact, the first week the baby is actually hypothyroid, and then the complications of the thyrotoxicosis that occurred at the end of the first week. The baby is excessively irritable. Maybe he can have tachycardia, congestive heart failure. Also, it can behave like fulminant viral infections. So that gets us confused whether we are dealing with a case of sepsis or a frank thyrotoxicosis. Then there can be hepatosplenomegaly. The child can be very lethargic. The liver enzymes can be, they can run havoc. So that is a very confusing state, but we should, keeping in mind that the mother had a history of Graves' disease, we should go for the TSH and free T4 level estimation and the receptor, thyroid stimulating receptor antibodies. So these are the, this is how we make out that the neonate may be dealing with a case of neonatal thyrotoxicosis, and we should start immediate treatment with methimazole. That is the preferred one in preference to propylthiouracil, because that also carries a risk of hepatotoxicity.
Same thing. So
also, we could add steroids and propranolol to the infant if there are fulminant, if it is a fulminant case.
So it is a double-edged sword.
Yes,
if it is undertreated, then there may be a TRAB, transplacental transfer of the TRAB, and there may be neonatal thyrotoxicosis, and most of the time it is overtreated. So we get the due to ATD, antithyroid drugs,
Exactly.
there is
and
fetal
the good news is that this
hypothyroidism.
is transient, so
Yes.
we have to monitor, and maybe over a period of 2 to 3 months, we can taper down on all of the drugs.
Yes.
And also I take the opportunity of this stage to just convey that congenital hypothyroidism is very much common, and it is the most common cause of preventable intellectual diseases in the newborn. So in our country it has not come up as universal screening, but we are doing more or less. We should screen for thyroid disorder like hypothyroidism, TSH and free T4 in around after 3 to 5 days of birth. That should be at least.
But I think in near future it will come as universal screening. It will come. Hillprick's test is becoming popular. So I am going to my last case. It will take only 1 minute. A 27-year-old, because we have started from pre-pregnancy, so we are going to the postpartum state. 27-year-old woman presented with 2 months after delivery with palpitation, weight loss, tremor, and excess sweating. No past history of thyroid disease. TFT was normal in pregnancy but was anti-TPO positive. No goiter, no eye sign but tachycardia. So here also we can see that FT4 and FT3 is high and TSH is low, but TRAB is negative, anti-TPO antibody is positive. Patient comes 2 months after delivery. So what will be the diagnosis and management? Any of the panelists?
The clear-cut case
Just
of postpartum thyroiditis,
yes.
and it is in thyrotoxicosis stage, and no treatment, active treatment is needed, except we may use propranolol like that to control the tachycardia, but unless no antithyroid drug is needed, and it will convert to normally to hypothyroid after a few weeks.
Yes.
Then it will convert to euthyroid state after 6 months or like that.
But we should be aware of the fact, because most of the time we see that they are they have already been treated with carbimazole or methimazole and the patient comes with profound hypothyroidism. So it is also an autoantibody mediated postpartum thyroiditis, just a destructive thyroiditis like our silent thyroiditis or subacute thyroiditis. So we should observe the patient and give supportive and symptomatic treatment. Patient in most of the cases, in 75% of cases, they revert, and 25% cases they may require L-thyroxine in future. So thank you very much. We have short of time, so we couldn't take.
Before leaving this topic, just 30 seconds I will take to the hall. Often we find patients telling that I am taking levothyroxine meticulously, but not achieving target level. The main 2 to 3 things আমি আমার practice দেখেছি, that is the silica powder or silica gel is there inside the bottle. Sometimes patient remove and discard it. So we'll have to counsel the patient, don't discard the silica gel, because moisture may hamper the efficacy of the drug. And second one, we should not change the brand. It is clearly written in the textbook of medicine of Harrison, don't change the brand whatsoever it may be. Eltroxin, Thyrox, Euthyrox, Thyronum, even Dawa India or Med Plus or Pradhan Mantri dokan, shop dokaner chok kore, sir, this medicine is not available, so changing the drug is the habit and regular phenomenon in our day-to-day practice. But don't change the brand whatsoever you are using, because it may hamper the absorption and may hamper the bioavailability, because every brand has unique bioavailability.
And another thing is the relation with the food. At least 1 hour gap should be given. If not 1 hour, at least 40-45 minutes. Most of the time they are actually in morning time, everyone is in hurry, so they take the medicine and then
tea or like that. It is not recommended.
So that is also not recommended. Thank you very much. Because of scarcity of time, we couldn't take questions from the audience. So thank you again. Thanks to the panelists and thanks to the audience.
Thank you, Sharmishta ma'am, and the panelists. Moving on to the next part of panel discussion, DK versus HHS, I would like to invite the moderator, Professor Dr. Jayanta Sharma, Professor and Senior Consultant of Apollo Hospitals, Kolkata. Over to you, sir.
Good morning, all my respected colleagues, my seniors, and all the delegates over here in this metabolic obesity conference in Taj Talkotir in Calcutta. So, as my previous speaker, Dr. Sharmishta, has been talked about the pregnancy and thyroid, and now we are moving again towards the diabetes management. in last day, yesterday, everybody was talking about the obesity, anti-obesity medications and diabetes, but the clinicians, the diabetologists, the intensivists, as a whole, as everybody is treating diabetes in our day-to-day clinical practice, and the most important emergency in diabetic management, one is DK and another is HHS. So where we are standing in clinically in 2026, and that is our topic today, and we have been panel discussion for this, DK versus HHS. Are we still managing them optimally in 2026? That is our topic, and I am requesting all my distinguished panelists, they are very renowned in city and established themselves in different area in state in their practice, and a moderator, as a teacher, as a faculty. So my first panelist is my senior and renowned diabetologist, Dr. Bishwajit Ghosh Dostidar. He is a senior consultant and director, Division of Internal Medicine and Diabetes in Woodland Hospital in Calcutta. Bishwajit Ghosh Dostidar, sir. My second panelist is Dr. Kaushik Hajra. He is presently working as a professor, Department of General Medicine in Bojboj, Jims Medical College Hospital. Kaushik, please. My third panelist is Professor Dr. Krishnendu Rai, sir. He is professor and head, Department of Medicine, Mednipur Medical College. Krishnendu, sir. The fourth panelist is Dr. Mridul Bera. He is a renowned diabetologist in Howrah and consultant physician and diabetologist in Narayana Hospital based on Howrah in Calcutta. And my fifth panelist, again my senior, Dr. Parthosarathi Mandal, sir. He is a senior consultant and diabetologist previously in AMRI Salt Lake Hospital. Now it has been named the Manipal Broadway Hospital, Salt Lake, Calcutta. So my distinguished panelists, good morning all of you and all the delegates over here. We are very happy we have got the platform to discuss this important topic in front of you. So as we just talked, everybody is treating diabetes. We are writing a lot of GLP-1, semaglutide, we are writing a lot of DPP-4 inhibitors and these things. But in clinical practice, besides this, we are sometimes facing the emergencies. So what are the two emergencies we are mostly facing? One is DK, another is HHS. So my topic is today is DK versus HHS. Are we still managing them optimally in 2026? Science is advancing, ADA guideline, ESD guideline, everything is changing every year. So with this, we are advancing our panel discussion. We have been given 30 minutes and we will ask all my panelists one or two questions each so that we can have a clear idea about it, where we are standing in 2026. So my first question to my distinguished panelists, number one, to Dr. Bishwajit Ghosh Dostidar, sir, starting from the basics and diagnosis. So before starting for any topic, we should learn about the basics as well as diagnosis, what is DK and what is HHS. So my first question to my Bishwajit sir, if you consider the etiology and risk factors in 2026, because we are standing in the April month in 2026, what is the most under-recognized trigger for diabetic ketoacidosis versus HHS that clinicians are still missing at this juncture in April 2026?
This is a very good question. The catch is 2026, and the most under-recognized trigger in this hyperglycemic emergencies. Now, we know that the recognized triggers are basically insulin discontinuation and infection. Infection is probably the commonest globally, but the most under-recognized trigger in this era, 2026, is probably some of the newer drugs that we currently are using in large numbers. And we all know that SGLT2 inhibitors, particularly after they are introduced as a generics, are being used in large numbers in both cities and in the rural areas. And it has a potential to cause what is known as the euglycemic DKA, which is a dangerous complication of this particular molecule, particularly if it is used in a undiagnosed type 1 diabetes or type 2 diabetes which severe insulin deficiency. So this is one thing that is probably that we should recognize as a potential trigger in this 2026. There is another drug which also needs a little bit of mention is the immune check inhibitors that we are also using in increasing numbers in various malignancies and some of the rheumatological conditions that also can cause autoimmune destruction of the pancreatic beta cells and can land up in DKA or HHS.
Yeah, thank you, sir. So the most under-recognized one is the infection, sepsis, or sometimes the lot of molecules which can causes the trigger the DK or HHS. So my next question is to Dr. Kaushik. From the pathophysiological point of view, what key pathophysiological differences explains why HHS develops profound hyperosmolarity without significant ketosis? What is the basic?
Thank you. So basically, what happens in diabetic ketoacidosis, there is absolute insulin deficiency. Now, due to absolute deficiency, so there is two things. One is increased number of the counter-regulatory hormones, so increased glucose production, and number two is activation of the lipase, so fat oxidation, so increased number of ketone bodies. But what happens in hyperosmolar coma, there is a relative insulin deficiency. So this, due to this relative insulin deficiency, so fatty acid oxidation usually halts. So there is no ketone body production or less amount of ketone body production, but there is a increased number of serum glucose. Due to this increased glucose, usually it's insidious onset, elderly patients, dehydration, so and any infection, sepsis. So it leads to severe dehydration and increased serum glucose leads to hyperosmolarity and profound dehydration. Now for this profound dehydration, there is at the cellular level, there is dehydration at the brain. So ultimately patient become comatose. So there is increased blood glucose, osmolarity is more, but ketone body formation is lesser as compared to diabetic ketoacidosis. So two differential main points due to pathophysiology is, one is in decay there is a profound insulin deficiency, and in hyperosmolar coma there is a relative insulin deficiency.
Thank you, Kaushik. The basic thing is, one is relative deficiency, another is absolute deficiency. There is a fat production and deficiency, it may causes the ketosis and hyperosmolar. So now third question is to Professor Krishnendu Rai sir. Clinically, because in Mednipur Medical College and bedside, what single feature helps you quickly differentiate DK from HSR in the emergency department? Practical questions for all the students.
DK and the HHS, we have to take the proper history first. In historically, DKs are the most of the cases of the acute presentation, whereas the HHS are a little bit of chronic presentation. DKs are mostly seen in the type 1, yes, definitely in the type 2, but mostly in the type 1. So younger onset, we have to consider much more DK, and a little bit of older, we have to much more considerations of the HHS. We have to think about what the dehydration status is that. If the dehydration status is very severe, that means there is hypotension, there is collapse. This situation is much more common in HHS in comparison to the DK. But if the question is that if what is the single feature, if we consider about the single feature, then we have to consider about the consciousness level. The most important thing is that in DK, the most of the patients are consciousness level are more or less preserved or little bit of drowsiness. But in cases of the HHS, as there is an osmotic shifting is there, so there is chance of consciousness level decrease is very, very high. So that they presented with mostly there's a stuporous to coma. So if we consider the single most clinical feature which differentiates between this DK and HHS in an emergency situations, always think about that, what is his consciousness level. So much more deranged consciousness level, the chances of HHS is very high.
Thank you, sir. Why I have been put this question, because Sometimes this question asked in the postgraduate examination as well as in the clinical examination in exam. So most of the students, what they are asking, sir, the blood sugar level, if it is very high, I will think about the HSS. If it is around in between 250 to 300, I will think about the decay. But nobody is thinking about the sensorium level. So for that reason, in bedside, whenever you are entering into the emergency and these things, the single point which can differentiate between these things, this is the catchy questions. For that reason, I have been put this question to Krishnan Durai, sir. So my fourth question to my next panelist, Dr. Mridul Vera, sir. Come to the diagnostic point of view. As you are roaming here and there all over the world, as well as you have been represented few days back in IDF as well as ADS, so for that question to you, do you still rely strictly on ADA criteria for DK and HHS, or we are now managing them as a continuum from the international point of view?
I think, sir, if you can see these ADA criteria for DK and HS, so DK, they have said that this is not the criteria that you have to do for ABG and go for the anion gap. And if it is a high anion gap, that you can say the patient is having the diabetic ketoacidosis. But they have not said it, they have said the point of what is the level of the beta hydroxybutyryl level. That is just most important. And from the HHS part also, this is the more of an hyperosmolar state, so you have to measure the osmolality more. So I think as a continuum we can also say, because I'm just talking from the HHS point of view. So if you can see this mortality of the HHS, it is about much more compared to the DK. It is around 15%, 10 to 15%, and with the DK only 1 to 8%. Now many of the HHS patients can also suffer from the DK, because the patient started with an hyperosmolar stage, then in many of the patients already taking SGLT2 inhibitor, or already the patient is very insulin inefficiency or deficiency, is absolute insulin deficiency, or that can also put into the decay state. So HHS and decay is very, very common compared to the decay plus HHS. So it can be said is a continuum. So HHS and decay, when it is combined, you can see the mortality rises from 15% to 50%. So I think accordingly you can say that as the decay patient can have and sometimes can hyperosmolar state, and on the HHS patient can also suffer from this is the diabetic ketoacidosis. So I think it maybe can say is a continuum, like type 1 diabetes patient more suffering from decay and type 2 more suffering from the HHS.
Yeah. Thank you, sir. Because if we can manage them individually, better than it is we should use them as a continuum. We don't know which patient is presenting at the time of emergency, so we should take it as a guideline, as a continuum. So my next question to my senior, my Dr. P.S. Mondal, sir, as he is practicing diabetology as managing the DK patients and HHS in corporate hospital for a long years, when I was a registered, most probably during that time. So I was noticing my sir. So P.S. Mondal, sir, from the practical standpoint of view, what is the most clinically meaningful difference between DK and HHS that actually changes management? Whenever you are entering into the ICU, what is the actual thing changes your management?
Yes. The important thing is that we have already discussed that in diabetic ketoacidosis, there is actually the absolute deficiency of insulin. That will lead to acidosis, and there will be wide anion gap acidosis. So we need to address acidosis, and patient requires insulin. Unless you give insulin, then you cannot prevent that lipolysis and generation of acid, that your acetones or beta hydroxybutyric acid. So basically, they require insulin from the very early part of the diagnosis. I am not saying that they do not require IV intravenous fluid. They are also dehydrated. But here insulin is fast, and in your HHS they are hyperosmolar, they are very much dehydrated, where they require IV intravenous fluid first, the IV fluid resuscitation first. Even with the correction with this fluid status, their blood glucose will improve. They require insulin later. So here my dictum is that fluid first, and in diabetic ketoacidosis, insulin first. They will also need IV fluid. And one important thing is that often what we do the big mistake with the correction of hyperglycemia and diabetic ketoacidosis, we believe that everything has been completed and we have done everything. But no, we need to continue that insulin so that we can prevent the ongoing process of this lipolysis. And here, these HHS, they are very much fluid deficit, roughly 10 liters, maybe 12 liters. So first 12 hours, we want to replace 50% of this fluid deficiency. And over next 12, 16 hours, we keep the rest of this fluid deficiency. Yeah. So these are the basic things. One is the insulin, they require, in the diabetics, they require insulin more, and here in the HHS, they require fluid more. But again, I'm not saying that HHS will not require insulin, but we can give after 6-8 hours. But initially they require this fluid. But here again, we should not correct this fluid deficiency very rapidly, then that can cause the shift of the osmolarity, and that can cause your cardiovascular instability.
Yeah.
These are the things.
Thank you, sir. So what we have been noticed in DK and HHS, in HHS we need the rapid correction of the fluid, whereas in DK we need correction of the hyperglycemia first. So we need the insulin in DK first, and in HHS the IV fluid is the most important thing, which practically changes the management in ICCU or in the emergency situation. So with this basic pathophysiology and these things, now coming to the management point and these things, what we should carry out the message for my students and everything in 2026. So I am coming to the second part of my discussion on panel discussion today. The severity and management. So we have been discussed about the pathophysiology and basic things. Now coming to the severity and management. Again I am coming to my senior and the first panelist, Dr. Vishwajit Ghosh Dastidas sir. So in severity classification, does the current severity classification adequately capture HHS risk, or are we underestimating its severity compared to the DKA?
Right. I think this is a good question. Often we underestimate HHS and tend to rather slightly undertreat than DKA. There are several reasons. I think we focus more on the DKA, both in our undergraduate levels, and we think DKA is actually more dangerous than the HHS, which is actually opposite, as everybody mentioned here, that the mortality of HHS is actually much higher. Part of it is actually due to underestimation of the risk of the HHS. Part of it is due to that, and probably we diagnose it a little late. Because the HHS, as was mentioned, that it is more of a subacute manifestation, and the decay is more of an acute. So the attention they get earlier than the HHS. This is one reason that probably the HHS mortality is higher. And regarding the severity, yes, I think the current severity classification of the decay is based on the extent of the acidity, the extent of the acidity, the pH. And the severity of the HHS is the extent of the dehydration. That is the standard, this thing. But whether we are underestimating the severity of the HHS compared to DKA, I think yes, we do. Because often the HHS, we underestimate, as Dr. Mundal was just now mentioning, the extent of the dehydration. The extent of dehydration can be as high as you mentioned, 10 liters. And we don't adequately correct the dehydration in stipulated period of time. And that actually leads to the organ damage very quickly, particularly the renal function and also, the CNS function. So yes, I think with the current levels of the estimation of the severity, of the both, of the particularly the HHS, we do underestimate. We should have a better way of estimating the state of hydration of HHS in current guidelines.
Thank you, sir. So in the severity, if you can talk about the severity of decay, so it depends upon the ABG and pH level. If the pH is less than 7.3, it is around mild. If it is less than 7.2, it is moderate. And if the pH is less than 7, it is a severe decay. So the severity criteria of a decay depends upon the pH level. So at the emergency, we should go for the pH, ABG should be done. And sir has been already mentioned about the fluid.
The only one comment is that,
yeah,
though we are not using regular basis, nowadays it is already it is available for nearly about decades. We are using acetone based, but actually we have to measure the beta hydroxybutyrate, and it has been documented that for a ketonemia, if it is less than 3, it's okay. 3 to 6, it is a mild, and more than 6, it is a severe.
Yeah.
So we have to much more dependent on this beta hydroxybutyrate, which we are not using regularly.
Yeah. So we should be also keep mind on that.
But we don't have that facilities. That is a problem. It is theoretical.
Is it
we all
high?
know that,
It is
but
high.
we don't have the facility.
Yeah. So just keep in mind over that. So my next question is to Dr. Kaushik. So triage. As you are managing your patient in Bajbaj Medical College and gyms, given the higher mortality of HHS, should triage threshold be stricter than for decay for HHS patient?
Yes, definitely. Both decay is also an acute condition, but in HHS, as Sarah has told, the severity is much more than decay, because we can see the mortality is usually more than 10% into 15%, and there is at least 10 to 12 liters of dehydration present in hyperosmolar state, and due to this dehydration, usually we got elderly patient with a known diabetic, long-term incidence, onset, loss of consciousness. So it leads to severe dehydration, which may ultimately go to AKI. And even this dehydration states may trigger prothrombotic states, and there may be chance of MI or cerebrovascular accident. And also during correction of the dehydration, it is a first priority in hyperosmolar state. We have to monitor, because too rapid correction ultimately leads to osmotic demyelination. So the close monitoring is needed. Even we can manage decay at ward, but if we have the facilities, then we should do the triage for the strict control of the management of the hyperosmolar state, because otherwise the mortality is very high, and so we should keep in mind this.
Thank you. So we should give a triage facility to the HHS patient, definitely in ICCU, and we should treat them very rigorously when the patient comes to in the ICCU or in the emergency or in the ward, whenever it has been diagnosed. So my third question to again Dr. Krishnendu Rai sir, from the management point of view. Now coming to the fluid, the most important aspects. In HHS, how do you balance aggressive fluid resuscitation with the risk of rapid osmolar shifts? That is the very important questions for all of you.
We all know that in HHS, the most important thing is that there is an hyperosmolality. And we all know that in hyperosmolality, we have to think about what is total osmolality and what is effective osmolality. Because in the point of care, we do the ABG reports. We do not get the urea report at that moment of time. So without urea level, we have to actually getting the effective osmolality. So we have to calculate the effective osmolality, and accordingly we have to treat the patient. The patient in HHS, most important thing is that there is a severe dehydration, nearly 10 to 12 liter dehydration. So actually the management is at least a 24-hour management. First 0 to 1 hour, then 1 to 6 hours, then 6 to 12 hours, and then 12 to 24 hours. First 0 to 1 hours, you have to do a 2 double bore needle in the 2 different veins. So that 1 needle you have to give the fluid at least 0.5 to 1 liter in 1 hour. If there is an hypotension is present, then it may be increased up to 1.5 liter. And one thing is have to be kept in mind, 3 things. One is that you have to check every hourly the osmolality level and the effective osmolality level. And you have to think about that this osmolality level to decrease 3 to 8 milliosmol per kg per hour droppage. If the droppage is much more, then that will be dangerous because there will be a shifting of the fluid inside the neuronal cells, there will be a osmotic demyelination. But if you do not correct it below 3, then there will be a dehydration will be much more. So we have this is a double-edged sword, we have to take care of these things. And another thing already Professor Dr. Mondal has been elaborately said that do not give insulin as a first line management of HHS, though there is a tendency that because of very high blood sugar, our inherent tendency is to decrease the blood sugar level by insulin, but not this is because whenever you give the fluids, so there will be the renal plasma flow will increases, there will be an osmotic diuresis, there will be decreases of the blood sugar level. If that blood sugar level do not go into the tune of that of 50 milligram at least, decrease per hour, then only you have to think about giving the insulin. Otherwise, you have to give the fluids at least for 4 hours, check for the blood sugar level decrease and check for the osmolality level. If still not, then you start the insulin. Definitely, before that, you have to check for the potassium levels. And the another thing is that you have to keep in mind that in insulin, in the HHS and in decay, you start at least a 0.1 unit up to the 0.2 unit per kg per hour. But in HHS, always go slow and go low, that is 0.5 unit per kg per hour basis. But always monitor the osmolality every 2 to 4 hourly and manage that first 1 to 6 hours correction of the volume, and then your management is depending on still on the osmolality levels, so that if the osmolality level is corrected or not, and accordingly you have to give the normal saline or 0.45% saline.
Sir, to you the question, sir. Whenever we are discussing in this, how the osmolality level, how much the osmolality level in initial period and how much we should decrease it?
Actually, to document that is in a case of HHS, the thing is that the effective osmolality, that is on the basis of the sodium and the glucose, it has to be more than 300. And the total osmolality, which is on the basis of the sodium, glucose and the urea, it must have been more than 320. So in HHS, after giving the fluid, your target is that to decrease that 3 to 8 milliosmol per kg per hour. Not below, not more.
So that was my question to you, sir. So next to my next panelist, to Dr. Midul Vera, sir. Come to the insulin strategy, because in DK as well as in HHS, our mainstay of treatment after the fluid is insulin. So regarding the insulin strategy, how does your insulin approach differ between DK and HHS, particularly in the initial hours? Little bit answer has been given by the Krishnendu, sir, but I am just again asking to you, sir.
So very pertinent question. Now, when you just see the decay, hyperglycemia is around more than 250, it only reaches up to 500. But in case of HHS, it always above 600, even up to reach of around 1000 milligrams. So initially, we can say that yes, that HHS patient need more insulin and decay patient, HHS patient more insulin and decay patient need less insulin. But ideally that should not, because when you just say the decay patient, it is mainly the acidosis part is the main thing. So you have to give the insulin from the very first, and you have to definitely give the fluid, and your approach will be you have to reduce the blood glucose is around 50 to 70 milligram on in the first hour, but too much of again the reduction is not much required. And you have to start the insulin is around 0.01 1 unit per kg per hour. So that is the thing. Now, then the recent update is that if you have the severe ketoacidosis, then you have to give the patient the IV insulin. But if the patient is, now recent update they say that if the patient is having mild to moderate ketoacidosis in the pH of 7.25 to 3 or less than 7 to 7.25, you can even start the patient to the subcutaneous insulin as well. You have to give the same dose, 0.1 unit per kg per hour, and then up to that limit that you have to target the blood sugar is around 150 to 200. If it reaches that, you have to give the either 5% dextrose and stop the insulin or half the dose of insulin. That is for the decay. For the HHS part, again the fluid is very important part, because if you do not give the fluid, if you give the insulin, that is the 0.05 in it, this is half of the dose of the decay patient, So there will be the much more of the cerebral edema. So this is a double-edged sword. If the patient is having too much of dehydration, it has a shrinkage of the brain, and if you give the too much of the insulin, so it will reduce the blood sugar, it will the cerebral edema will occur. So in that approach, in the HH patient, you have to give the half doses of that has been done by this in the decay patient. So you have to give that is the fluid. But most important thing is the potassium level also. If the potassium level of less than 3.5, don't give insulin in any of the situation, either DK or HHS. You have to correct the potassium first, then you have to initiate the insulin. Even if the patient is having 3.5 to 5 potassium, then you have to give both the potassium and also the insulin. So this accordingly, the insulin is important, but the approach is different.
Yeah, very pertinent, because most of the time we never think about the potassium level. So correction of potassium is very, very important in management of DK as well as HHS. So we should be very careful about the potassium level whenever we are starting the management of the DK and HHS. So my next question to again Dr. P.S. Mandal sir, from the management point of view. So regarding the treatment principles and prevention, if you had to prioritize one principle, what matters more in outcomes, early fluids, insulin timing, or identifying the precipitating cause?
Yes, I have already mentioned that in DKA they require insulin early, as soon as possible with IV fluid. In HHS they require fluid early, and we would give the insulin later on. And I usually prefer that fixed insulin rate infusion, that fixed rate, as we have discussed, that 0.1 unit per kg of the body weight in DK and 0.05 unit per kg of the body weight in your HHS. And one important thing we haven't discussed, that when in the DK the blood glucose approaches to 200, then we need to change the IV fluid to the dextrose containing IV fluid, because unless you don't give this dextrose, then that your lipolysis will be continued and there will be the production of the acetone. And to prevent that this process, patient requires insulin, unless you give dextrose from outside, they will end up with this hypoglycemia. So there is one thing for HHS, when the blood glucose is 250 to 300, you can start this dextrose intravenously. So these are the things. And one important thing is that always you need to find out the precipitating factors, causes. Most of the cases in your type 1 diabetic subjects, which is the omission of insulin or intercurrent infection, could be UTI, could be this LRTI or pneumonia. Or another important thing is the pancreatitis is also important cause. And both in type 1, type 2 diabetic subjects, again your myocardial infarction, stroke, these are also the precipitating, could be the precipitating factors. And already Dr. Ghosh, those that discussed that SGLT2 inhibitor or other medicines like steroid, also the ketogenic, and sometimes some antipsychotic medicines also could be the ketogenic. And we need to remember all those things. But most of the cases type, what happens actually practically, that when they suffer from simple things like viral illnesses and they won't take any food and drinks, and parents, what they think that if we give insulin, that can cause hypoglycemia, and they stop it. That's the important thing. And that can cause the diabetic. I am telling you the fact that I lost one type 2 diabetic subject, lady with the diabetic ketoacidosis, euglycemic diabetic ketoacidosis. She had been on basal bolus insulin and your DPP-4, metformin and SGLT2 inhibitor. She went for vaccine Darjeeling, and she felt that she doesn't require insulin. So she continued these oral anti-diabetic agents, and when she came back in the Howrah station, and she was absolutely acutely ill, and she was admitted, but we lost, because the learning point is that even in the type 2 diabetic subjects, we should not stop this insulin when they are on SGLT2 inhibitor. That can precipitate this diabetic ketoacidosis. And for the HHS patient, they require DVT prophylaxis, you have already mentioned, and as they are obtunded and their consciousness is very low, there is the increased risk of pressure sore. So we need to also look at that thing.
Yeah. Thank you, sir. So before we conclude our panel discussion over there, So what we have been learned, 1, 2, 3 things. One is both of them, DK as well as HHS, both are diabetic emergency, usually present in the emergency department as well as in the ICU. So before starting the treatment for the DK, the first line of treatment is to start the insulin properly, and for the HHS, treat the patient's fluid deficit should be corrected properly. So these are the 2 things. Third thing, we should take care of the potassium part. Unless or until we take care of the potassium part, we have to be goes into the loop. And fourth is the always try to find out the underlying cause which may precipitate the DK and HHS. So before I concluding to all my panelists, take home message, single line from 111. 111 please. From a
Yes, the important thing is that often...
single message, one.
Yes, often we miss diagnosis of HHS. We need to be more alert because most of the cases it happens in the elderly subjects. Often they have the other comorbidities. We focus on to those comorbidities and we miss it. So that is the important. We need to consider the diagnosis of HHS when we see the hyperglycemia in the elderly subjects and they are sensory with the altered sensory. We need to exclude the, yes, of course we will exclude the stroke, other things, but we need to consider HHS strongly in this subject.
Mridul Vera sir, one sentence please.
One sentence for resolution.
Take home message, yeah.
Resolution for DK patient, improvement in the acidosis. If it is acidosis improved pH over 7.3, so that is then you can definitely, the patient is having resolution. For the HHS, improvement in the osmolality. That is important because there is the recent guideline said that is not the confusion, the alertness that has been improved, not the criteria. You have to show that the patient osmolality has decreased. So that is the main thing.
Krishnendu sir.
In case of diabetes, comes in emergency, always take history, examinations and do an ABG so that you can identify whether there is an HHS, whether there is DK or there is mixed, because there is always chance of mixed of DK and HHS.
Kaushik please.
Drug history is very important. As Shahid has told, sometimes we miss the euglycemic decay. So whether patient is taking SGLT2 inhibitors or not, and whether patient has stopped insulin in acute illness, you have to ask. The history is very important.
Vishwajit sir.
One thing is often not discussed in decay issues is the readmission or the rehospitalization of the decay, which is very, very common. 1 year rehospitalization of decay is, I don't know, I mean, it varies in different countries, but it's extremely high. But it has been recognized currently that a very strong association is psychiatric illness. And it is recognized, I mean, with such a seriousness that the current area guidelines has included all hyperglycemic emergencies patients in hospital should be screened for professionally for major psychiatric disorders.
Yeah.
PHQ9 screening tool is a basic screen. Yeah.
So thank you sir. Thank you all my respected panelists and all my delegates in these things. So with this we are concluding this panel discussion over here. Hope everybody has taken some good message from this discussion and you will utilize in your clinical practice. So I am requesting all of you to stand over here and take a photograph together.
Yeah. Just can anyone take some photographs for all of us? Yes. Yeah, it's your session. Thank you, sir. We are running a bit late. Thank you, sir. We will come to the miscellaneous topics, that is the neurosurgical perspectives in obesity and metabolic control of hypothalamus, which will be spoken about by Dr. Dibyendu Kumar Roy, who is Professor of Medicine, KPC Medical College and Consultant Internal Medicine Rheumatology at Fortis. He has several publications to his accord. Over to you, sir.
So from the very academic and clinical discussions that we had, we come to a more research-oriented topic till now. This is hypothalamus and beyond, neurosurgical perspectives in obesity and metabolic control. This would be the flow of the talk. The discussion is essentially academic as current neurosurgical approaches are still largely investigational. And my personal experience is largely on DBS and VNS for other indications. So neurosurgical, basically neuromodulatory management of obesity is not the first line of treatment. It is generally reserved for severe refractory obesity where lifestyle therapy, pharmacotherapy and bariatric surgery have failed or are not feasible. And the most feasible option till now has been vagal nerve modulation, basically vagal nerve blockade, and other brain targeted procedures like DBS are still primarily in research settings. So the clinical rationale behind such approaches at the hypothalamus is the seat of homeostatic control. It integrates and regulates hunger and energy expenditure through meal initiation, through the orexogenic hormones, and meal termination through the orexogenic hormones. The mesolimbic reward system, which controls hedonic eating, and the related pathways that drive food craving and reinforcement through guided food choices. The corticostriatal networks, the prefrontal cortex and the amygdala, which play a role in impulse control, decision making, and compulsive eating patterns, and also guides the food choices. The hypothalamic control of metabolism has a control over multiple factors: the eating behavior, energy expenditure, behavior, sleep, temperature regulation, and the pituitary functions. To consider neurosurgical approaches, we should have a patient with severe obesity with BMI often more than 40 and serious comorbidities despite structural interventions, failure, intolerance, or contraindications to intensive lifestyle therapies led by dietitians or nutritionists, contraindications or intolerance to anti-obesity medications like GLP-GIP agonists or GLP-1 agonists, contraindications to bariatric surgery or failure to maintain weight loss after surgery. This could be because of prominent hyperphagia or cravings or care, and for this care should be available through multidisciplinary team of endocrinologists, nutritionists, psychiatrists or psychologists, anesthetists, and last of all a neurosurgeon. The important exclusions or contraindications include active substance abuse disorders, uncontrolled psychiatric issues, inability or unwillingness to adhere to follow-up schedules, because all these interventions require strict follow-up schedules, and medical contraindications to implantation like an active systemic infection or contraindication to anesthesia. With the current war, I would think of our armamentarium as the arsenal. The first one would be a vagal nerve blockade. The concept is that it modulates vagal signaling between the gut and the brain to reduce hunger and improve satiety. It engulfs an implanted device with leads placed laparoscopically near the vagal trunks, delivers intermittent blockade. It has been in clinical use, but obviously less commonly than pharmacotherapy or bariatric surgery. And at best, it can provide a modest to moderate weight loss in selected patients, may improve the metabolic parameters thereafter. The weight loss is obviously less than bariatric surgery and often less than incretin based medications and require device management and follow-up. the risks of surgical risks of infection, pain and lead issues, lead displacement, lead breakage and all that, and need for revision. GI symptoms can cause nausea and dyspepsia and device malfunction. Vagal nerve stimulation, it's that hyperstimulation of the vagus can produce the same results as vagal nerve blockade, and obviously thereby influence appetite, satiety, and autonomic balance. Vagal nerve stimulation is much more established for epilepsy and depression. For obesity, it is not an established procedure and evidence is mixed. Here comes the prime, deep brain stimulation. Looks attractive, very attractive, but still investigational, used only in research settings. Targets studied have been the hypothalamus, both the lateral and the ventromedial hypothalamus, and the reward circuitry, the nucleus accumbens in the basal forebrain. The rationale is that obesity can involve altered homeostatic and hedonic feeding pathways. It is still in clinical trials. It is thought that the potential benefits would be appetite and craving modulation and possibly metabolic effects. And the risks are all those of intracranial surgery, bleeding, infection, seizures, hardware complications, and the need for programming and follow-up. So what constitutes DBS is basically DBS is basically a brain pacemaker. It constitutes a subcutaneously placed pulse generator connected with electrodes to specified targets inside the brain. It is like other pulse generators which can be remotely connected to a computer and programmed. And the characteristics of any stimulation like pulse width, amplitude and frequency can be adjusted for each individual. The current is thought to depolarize axons and which may stimulate or innervate a particular area where the electrodes are placed. The practical clinical position for surgeries is that it is basically fourth line. The first line are your intensive lifestyle interventions and follow-ups. Second line is that you all discussed are the now highly effective modern anti-obesity pharmacology. Third line is the bariatric and metabolic surgeries. And fourth line, we come in last. Only in exceptionally refractory cases, ideally within clinical trials, when there is severe, uncontrollable hyperphagia, including hypothalamic obesity, and prominent compulsive binge eating, refractory to medical care, and in patients in whom bariatric interventions are contraindicated. There are certain ethical perspectives to such approaches. One is informed consent. We should be certain that the person is medically driven to such an approach, not through peer pressure, not being forced by other factors. So, patient autonomy, risk disclosure, and long-term implications of hypothalamic modulation, which you are not yet aware of, need to be disclosed to the patient. And in our country, the second point is very difficult, equitable access. Given such research settings, it is very difficult to ensure fair distribution of neurosurgical interventions for obesity to all those who need it. And affordability is a big question. So neurosurgery plays only an auxiliary role in obesity management. You all are the front runners. We target the hypothalamus and offer some innovative solutions in refractory and metabolic cases. But above all, for such programs, we require a synergy. We require a synergy with nutritionists, psychiatrists, and you all, endocrinologists, to foster a comprehensive care model. Without a comprehensive care model, it is useless. to address the complexity of obesity at neurobiological levels. This is some of the reading material. If any of you want to have a look, you can have a look. And thank you for your attention.
Thank you, sir. Coming on to the next topic, that is PET CT scan in parathyroid adenoma, I would like to introduce Dr. Dipanjan Mitra from Department of Nuclear Medicine, North City Diagnostic Center, and ex-HOD of Nuclear Medicine at AMRI Hospitals, Kolkata. He has many publications to his CV, and over to you, sir.
Thank you so much. Good afternoon, everybody. Now, this is going to be a new kid in the block in the entire PET-CT gamut. I will not say much about the theory aspect of it because it does not make any sense. And so all of you are aware of PET-CT because, but there are certain myths about it. First myth is this is a radiological modality. See, PET-CT does not come under radiology. I am not a radiologist. This is a nuclear medicine specialty with a separate specialization. Second myth is PET-CT is used only in oncology, which is also not the case. There are applications of PET-CT in, say, PUO, say, all other inflammatory conditions, cardiac diseases, brain PET is for dementia, epilepsy. So there are different indications for doing PET-CTs. Third is FDG, that is fluorodeoxyglucose, which is the main isotope that we use for doing PET-CT, is a dye. A lot of people say FDG is a dye because our traditional conventional teaching about any scan, for that matter CT or MR, that we inject a dye or contrast for an image. FDG is not a dye. For example, and similarly, all other molecules that we use in PET scans are not dyes. They are isotopes or radiopharmaceuticals. They are mostly biomolecules, so they do not react to patient's body. I mean, the anaphylaxis and all other things are rare in PET-CTs unless we use a contrast for doing CT scans. And lastly, that one needs a separate CT study in a PET-CT. We do not need, it is a whole body study. Whole body means generally we do a head to mid-thigh scans in all PET-CT patients, and when we do a PET-CT scans, we generally use contrast CT whenever required. So this is how the technology evolved from CT brain, and then PET scans. The first PET scan of the brain was done in Pennsylvania in 1975, and this is in the year 2001, PET-CT as a modality came into the picture. So, and from there on, if you look even the picture of our own city, there was only one PET-CT machine in 2009 and 10. And if you in 2026, that is in 16 years, we have around 30 PET-CT in this city only. So it is a fusion of anatomy and nuclear medicine, that is the anatomy and physiology. The CT part gives you the anatomical details, and the PET part gives you the physiological details. Both put together, we say this is a best marriage between radiology and nuclear medicine. Now, coming to the topic of parathyroid imaging, because this is the central key interest for this talk, we all know that hyperparathyroidism, and particularly parathyroid adenoma or adenomas, are important to be detected because these days we are doing minimally invasive parathyroid surgeries. For that, what we need is to detect or precisely localize the parathyroid adenoma, whether it is a single parathyroid adenoma or multiple parathyroid adenomas. And the standard algorithm of imaging is doing a neck USG and sestamibi scan. Now, when we do a sestamibi scan, we do a 10-minute image and a delayed 2-hour image, and if there is a retention of the isotope in the region of parathyroid, we call it a positive scan. So in all suspected hyperparathyroidism patient, the algorithm is USG and a sestamibi plus minus a very specific kind of a CT scan of neck, which is called as 4D CT. So these three things are generally done in any suspected hyperparathyroid patients, and we need to have at least 2 concordant imaging to localize one gland. Now, if we compare the USG with the Sestamibi, as you can see, Sestamibi is far more superior in terms of its sensitivity and specificity and detection rates. Because there are some limitations of USG, like one is operator dependent, there is a short neck, multinodular goiters, the USG cannot differentiate at times with the parathyroid gland or the thyroid nodule, and ectopic glands, because the parathyroid glands may be ectopic, they can be located in the chest. That is why in any Sestamibi scan, or for that matter any dedicated parathyroid imaging, we need to include the mediastinum, because we may not see any parathyroid adenoma in the neck, but it might be so that the ectopic parathyroid gland is secreting the excess amount of PTH. So why Sestamibi? Because it localizes in mitochondria. We say Sestamibi is a poor man's FDG, because somebody who cannot afford to do an FDG PET even for malignancy, in earlier days we used to do Sestamibi scan. So it localizes in the mitochondria and it localizes in the parathyroid tissue, abnormal parathyroid tissue. So this is how a Sestamibi scan looks. If you see, this is a tracer retention in 2-hour study. So this is a localized parathyroid adenoma in a Sestamibi scan. And this is, these days we are doing a SPECT and SPECT CT study, so that there is a 3-dimensional fusion imaging, so that we can localize the lesion even on radiological studies. But there are limitations of Sestamibi, particularly if there is a multi-gland hyperplasia, very small lesion, and concomitant thyroid nodule. So Sestamibi may miss, so its accuracy rate is limited. That is why there was a search for newer scans, and we got to have 2 new radiopharmaceuticals. One is FCH, that is fluorocholine PET-CT, and the latest kit is gallium-68 trivexin. I'm sure all of you have heard about DOTANOC study, DOTATOC PET or DOTANOC PET, which is a somatostatin receptor PET-CT. And similarly, there is something called PSMA PET-CT, that is prostate-specific membrane antigen PET-CT. These are all different isotopes. Most of the PET-CT departments can do all these scans. So DOTANOC studies are somatostatin receptor imaging studies. They are used for neuroendocrine tumors, all kinds of neuroendocrine tumors, well differentiated. PSMA is, as the name suggests, it is only for prostate adenocarcinomas. Similarly, trivexin is an incidental finding. I'll come into it. FCH PET, as I told you, FCH PET or fluorocholine and trivexin, both are good in parathyroid imaging. But the availability of FCH is very limited in the country. There are 1 or 2 centers which produce FCH, hence the transport of the isotope from say Delhi or Bombay becomes a logistical issue. We ordered one FCH which was supposed to arrive in Kolkata at 9 o'clock, which did not arrive till 12 o'clock in the midnight. So, and these are all isotopes, so the decay in every hours, So this is how FCH scan looks. Now coming to gallium trivexin, what it is an integrin receptor targeter. So this is an alpha nu beta 6 integrin receptor, it targets those receptors, and what happens is in all epithelial cancer cells there is overexpression of these integrin receptors. So there is whenever we are injecting an integrin receptor analog which is radio tagged, it will localize in those tumor cells. It was an incidental discovery in Turkey. So there is an initial seminal paper by the University of Turkey that they showed they were doing scans for pancreatic adenocarcinomas and head and neck malignancies, and they found incidentally a lot of parathyroid adenomas being picked up on these scans. So this is the paper. This is initial studies, so it is not that multiple papers have come, but then most of the centers are now doing these scans in their daily practice. So what they did is they studied 13 patients with biochemical hyperparathyroidism. 3 of them had MEN syndrome and 10 patients had sporadic hyperparathyroidism. They all underwent the basic algorithm of USG, Sestamibi scan, and some patients had a 4D CT scan of neck, and few patients had fluorocholine PET-CT. All of them were subjected to this trihexyvin PET to compare the data, and what they found is there were 3 patients which were not picked up by USG. So out of remaining 10, there were 8 lesions which were identified by USG confidently, but 5 were indeterminate. The detection rate of system AB was 10 out of 17 for lesion-based analysis and 10 out of 13 for patient-based analysis. Now, when we compared the data with the Trivax in PET, the detection rate was 11 out of 13 as per patient-based analysis. That is, there were 13 patients, 11 out of 13 patients were detected with parathyroid adenoma on the Trivaxing PET CT. So, detection rate was 84% as per patient-based analysis and 94.1% as per lesion-based analysis. So, I'll just show you a few cases. As you can see, these are all hyperparathyroid patients. These A and B are sestami B images. As I told you, sestami B images are generally two sets of images. One is taken 10 minutes after injection and the other is taken 2 hours after injection. That is why it is called delayed sestami B scan. And we look for retention of the tracer. These two lobes which are seen in the first 10 minutes is the thyroid. So, this is a normal thyroid biodistribution of the isotopes. Only if there is retention of the tracer in the area of parathyroid in a delayed scan, we will call it a positive scan. Here if you see after 2 hours, the isotope has actually washed out. So, there was no localization. So, this is a negative sestami B scan. When a Trivaxine scan was done, we saw there is a focus of radioisotope concentration in the neck on the corresponding CT, as you can see in this red blob. So, this is the actual parathyroid adenoma which was picked up. So, it is a sestami B negative and Trivaxine positive PET scan. Similarly, it is a man with a MEN syndrome. As you can see, this is the A is a sestami B early scan, 10 minutes. If you see, there is an arrow which shows there is a small tiny isotope below the level of the right lobe of thyroid. So, there is again a little bit of isotope trapping in the same region at the 2 hours. So, there was a suspicion that there is one adenoma in the right inferior parathyroid gland. When there was a Trivaxine PET CT done, as you can see, there are 3 arrows in the F image. So, if you see the corresponding G, H and I images, that is the CT. So, you see there are 3 parathyroid adenomas which were picked up. And this is my last scan. As you can see in this female patients, the MeB scan, that is the sestami B scan A and B, did not pick up any lesion. So, they did a fluorocholine PET CT. They found this E image. If you see, they found one tiny focus of isotope concentration, but then they did an US guided PTH washout analysis which found negative. But Trivaxine PET CT showed another uptake in the neck which is on the left side. That FCH showed on the right side, which on the FNA washout was come out negative. But then when they did a Trivaxine PET CT, it is a left-sided parathyroid lesion which is surgically removed, and this is the true parathyroid adenoma. So the take home is, whenever we are dealing with a parathyroid or hyperparathyroid patient, the first investigation of choice is USG. Second is sestami B with a 2-hour delayed scan with plus minus PET CT images. If it detects, then it is fine. Else you add a 4D CT scan. If all of these do not give you a conclusive answers, then you do a Trivaxine PET CT. Now it is up to the clinicians whether they use PET CT as the first line or the standard algorithm. Time will only tell, because we have to really design a study wherein we will go the conventional way and we will add PET CT as the first modality of choice, whether that is most cost effective. Because we have done the same for PUO patients in FDG PET CT, when in-hospital patients were admitted say for 7 days and they did a CT chest, CT abdomen, they didn't find an answer, they did an ultrasound, they didn't find an answer, and they did a PET CT. And PET CT gave them an answer for the PUO. So in the cost analysis, we found that the PET CT became more cost effective because the hospital stay comes down and all other expenses come down. So this is what I had to say. So the new kid is the Trivaxine PET CT, and most of the centers even in our city can perform them. So it is, time will tell how much popularity it will gain. Thank you so much. Thanks very much.
Thank you, sir, for the insights into the innovative approaches of PET CT. Going on to the next topic, that is neuroimaging in altered sensorium in diabetes. stroke, infection, or metabolic crisis. I would like to invite the speaker, Dr. Govinda Parmanik, for the proceedings. Over to you, sir.
Good afternoon. So first I would like to thank the organizing committee for inviting me every time for this EMOCON. So in the morning when I came, I was attending one very good clinical panel discussion which was mainly on DKA and hyperosmolar hyperglycemic state. These are basically clinical, not imaging diagnosis most of the time. But of course, sometimes we can bridge the gap with the neuroimaging between the clinical diagnosis and the management. So, what we know that diabetic is has a very unique vulnerability. Diabetic brain is very unique vulnerability to stroke, infection, and metabolic crisis. So let's see over next 10-12 minutes, I would like to show you a few images related to all these cases like vascular stroke, infections, and metabolic crisis. So when a patient comes, diabetic patient comes in altered sensorium, in confused state, our first instinct is to do CBG with the stick. So, but we should not tunnel our vision into the glucose metabolism only. We should go beyond that. We should see whether there is any stroke, infection, or anything else. So the algorithm in such case should be after the initial management of airway, breathing, and circulation, and the blood glucose level and initial lab investigations, we should always do a CT scan in a patient who is diabetic and in altered sensorium. The CT scan, only non-contrast CT scan is sometimes very helpful. So where we can, here we can see in this case, so many many pathologies like big hemorrhage we can detect on the NCCT. Here we can see that there is a large hemorrhage in the left basal ganglia region, and then we can detect subdural hemorrhage, even subarachnoid hemorrhage. Not only hemorrhage, we can detect ischemic stroke also. Here in the last image we can see there is a large territorial infarct in the left MCA territory causing significant mass effect. So in the CT scan we can, apart from this established infarct and hemorrhage, we can also detect evolving very early stage of infarct. Like in this case where we can see there is a white ribbon-like appearance in the left MCA region. That is actually, we call it hyperdense MCA sign. In such case, patient presents with hemiplegia, gauge preference, and neglect, hemi-neglect. So if we can, as a clinician, we can pick up these findings on the NCCT. We are just seeing this hyperdense MCA sign and patient presents with such a devastating neurological deficit. So we should suspect acute stroke. And if it is in the window period, we can manage it by mechanical thrombectomy. And we can salvage the patient within, if patient comes within the window period of 6 hours. So in such case, if we see this kind of appearance on NCCT, just on the NCCT, we should always ask for CT angiogram to rule out any large vessel occlusion so that we can salvage the patient by mechanical thrombectomy. Again, in diabetic patient, we have seen basilar occlusion. Sometimes we see that's another dreaded thing we come across sometime, where again on the NCCT we can see the dense basilar artery and patient is drowsy, almost unconscious, and in such case again we should ask for CT angiogram, and here we can see the basilar artery is not seen. In such patient also, if patient comes in window period, we can salvage the patient by doing mechanical thrombectomy. And this is one very interesting thing, I think diabetic patient related. It's like a spotter for our radiology resident, where we can see that this NCCT scan, just when patient comes with a unilateral hemichoria and hemibalismus. So we do the CT scan, and when I was a resident, first saw this scan, I thought whether it is a bleed on the left basal ganglia. But when I came to know about this entity, I found it very interesting. So it's a case of non-ketotic hyperglycemic hemichoria hemibalismus, and on the NCCT it's very typical. We can see the hyperdensity into the caudate head and the putamen, that is the corpus striatum. That's why it is called diabetic striatopathy. So it's a spot diagnosis. So on the just by the plain CT scan we can diagnose so many things, stroke and metabolic things also. And in some condition like DKA, where we expect marked cerebral edema, though it is not a imaging diagnosis, it's a clinical diagnosis, but later on we can do imaging and we'll find diffuse cerebral edema. So that also we can pick up in just by plain CT scan, which is easily available everywhere. So here in this image we can see that there is diffuse loss of gray-white matter differentiation, and we can't appreciate any sulcal space and the ventricles. So this is a tight brain. So when this condition, we should not wait for this image to happen. We should start the treatment just before the scan if you suspect DKA. Next thing is just plain CT scan is negative. What we should do? We should do always, patient is in altered sensorium and CT, plain CT is inconclusive. You should always ask for MRI. And I will tell the most important sequence here for in diabetic patient, we always do diffusion weighted imaging. There is one sequence called DWI, which is very important. So what do we see in this DWI? So DWI is actually diffusion imaging, where we see the restriction of the water within the brain parenchyma, and where there is restricted diffusion, it appears bright on the DWI image. So this is very important. So usually most of the metabolic problems in diabetics, we see there is a symmetrical appearance, right and left. Here, like in hypoglycemia, hyperglycemia, most of these other crises like uremic encephalopathy, all these metabolic crises on the imaging will get some kind of symmetrical appearance on left and right. Here in this case also, this is MRI DWI scan I was talking about. It is very important, and this sequence, particular sequence, is a very short sequence. So even this altered sensorium patient is restless, we can get a good picture of this DWI image. So this is very important. So here, this is the case of hypoglycemia, hypoglycemic encephalopathy. So you can see there is symmetrical appearance on right and left, the cortical ribboning, and the basal ganglia involvement on the bilateral side. One important thing in this hypoglycemic encephalopathy, sometimes it can be similar to global hypoxic injury. In those cases, you should keep one thing in mind, that in hypoglycemic encephalopathy, there will be sparing of the thalamus and brainstem. Only the high demand zones are affected symmetrically. So you can, if even after glucose correction, sometimes patient is not responding as you expected, so you should look at the thalamus. So if thalamus is involved, then you should think some mixed kind of pathology like hypoglycemia and hypoxic injury. So as I said that if it is symmetrical, most of the time it is metabolic crisis, but asymmetric lesions can be also cause altered sensorium, like a large territorial infarct in brain that can also cause altered sensorium. Here we can see there is this is again the diffusion weighted imaging, which is very important to pick up early ischemic changes. When CT is normal, you can do the DWI, you will see the findings very clearly. So here you can see there is this is a DWI scan where we can see a large diffusion restricted area which appears bright, and we can see, and the corresponding ADC map, we call this ADC map, it becomes dark. So when you get this kind of appearance, that means you are dealing with an acute stroke. Not all stroke is only unilateral. One important thing that is stroke, that is small stroke, arterioperturan territory stroke, where we can see it is symmetrical involvement of the bilateral median thalami, where it is a arterioperturan territory stroke. This is, as there is thalamic involvement, patient, though it is a small stroke, it is a strategic stroke, thalamic involvement can cause significant altered sensorium in such patient. So why it is symmetrical? Because arterioperturan is a perforated branch which comes from the proximal posterior cerebral artery and supplies both sides of the medial aspect of the thalamus and the rostral midbrain. So we will get symmetrical appearance. So like this is again the DWI, where it may be missed on the CT scan, plain CT scan, but on the DWI we can see very clearly that there is involvement of the both paramedian thalami. Again, asymmetric lesion, like when there is a temporal lobe involvement, you should think about herpes encephalitis in a diabetic patient. As you know, the diabetes is immunocompromised state, so this infection can occur. And if you see the ring-like appearance in the brain, and on the post-contrast scan, if you see this kind of ring-enhancing lesion, and in the DWI again showing there is central bright appearance, that is a restricted appearance because of the viscous pus. So you should think about a pyogenic abscess, and the most dreaded one is the mucormycosis in diabetic patient, when rhinocerebral mucormycosis. So in those cases I will show you some signs. So symmetrical appearance can also be seen in like diabetic patient, or when there is a correction happens because osmotic demyelination syndrome. Here we can see again the DWI sequence where we can see owl's eye appearance in the pons. So it is ODH, osmotic demyelination syndrome. So central pontine myelinolysis, it's owl's eye appearance, very classical. So and again on the T1, if you though it is very clearly seen on the brain CT scan, sometimes on MRI, on the T1 sequence, a non-ketotic hyperglycemic coma can present like this. Though it is unilateral, but it can be bilateral sometimes, bilateral stratopathy, classical hemichoria hemivalismus appearance. Sometimes hypertensive crisis, we can get press-like appearance, that is the posterior reversible encephalopathy syndrome, where we can see bilateral symmetrical areas of T2 and flare hyperintensity involving the right occipital region. So it's a classic appearance of the posterior reversible encephalopathy. Sometimes, especially in few cases of MALA, that is a metformin-associated lactic acidosis, you can get this kind of symmetrical appearance, that is uremic encephalopathy. One sign is described here that's quite interesting, that is the lentiform fork sign. Just one more slide. So where we can see that there is a it appears, the both basal ganglia appears lentiform fork-like appearance because of this hyperintensity along the internal capsule, external capsule, and external medullary lamina and internal medullary lamina. So this is bilateral lentiform fork sign that's classically seen in the uremic encephalopathy, sometimes in metformin associated lactic acidosis. Again, hypoglycemia, as I told, it's a symmetrical appearance. DWI can show classical appearance, where the classical sparing of the bilateral thalami, so cortical ribboning and the basal ganglia involvement. Mucormycosis, as I said, that it's a very feared complication in diabetes. If you are suspecting, then you should do at least a PNA scan. PNA scan in the MRI, you will get different types of appearance like that. One is the black turbinate sign, that is because you can see in the post contrast scan, the other turbinates are quite enhancing, but this turbinate is not enhancing because of the necrosis. So this is called the black turbinate sign, which is quite classical for mucormycosis. And another one is the Gitter-Pick sign. If the mucor as you know, it's an invasive lesion. So if it invades into the orbit, it can cause Gitter-Pick-like appearance of the globe. So this is called the Gitter-Pick sign. And as it is angioinvasive, it can grow into the brain, cavernous sinus, and the IC occlusion can happen, and it can cause mucor stroke. So what is the high-yield teaching points from this presentation? So you should not think about glucose, you should glucose-driven injury, you should think about non-glucose-driven injury like stroke in a patient with altered sensorium, and that is the most common actually. So metabolic cause is of course when it is when hyperosmolar and hypoglycemic state. Apart from that, uremic encephalopathy and osmotic demyelination syndrome. All these have a classical signature appearance on the imaging, as I showed. So symmetry is metabolic clue, and for infection always look for enhancement and diffusion restriction, and always correlate with glucose and lab findings. And my suggestion is, when you are sending your patients, diabetic patients with altered sensorium, always mention the glucose level and the duration and how is the onset, so that we can give a correct diagnosis. Thank you. Thanks for hearing.
Thank you very much, sir. Moving on to the next topic, that is cutaneous markers of diabetes. I would like to introduce Dr. Nidhi Jindal, who is a consultant dermatologist who is presently working at Olivia Skin and Hair Clinic, Apollo, and Tata Medical Center. Over to you, ma'am.
Hello everyone, I know this is my last lecture and it is an inter-speciality, inter-meet. I will not take much of your time and I will try to make it as interesting and crisp as possible. So my topic would be cutaneous markers of diabetes, early clues to a silent disease, and it's awesome. I, as a dermatologist, I always feel privileged because we can see what others can't. As our previous lectures where they have to dip into a lot more investigations before we conclude anything, but we are at the advantage hand. So basically, I would like to just start with a story, and it's a very small story, I will say. I had a patient who was good looking and she was very lean, and yet she was very stressed because she said to me, ma'am, everything reacts to me. All her perfumes and deodorants, and she think that the pigmentation in the underarm is because of the perfumes and the deodorants she was using. But on examination, I saw that it was not only the pigmentation or an allergic patch, but it was a dark, hyperkeratotic or thick skin with the blackish brown pigmentation. For me, it was a very clear-cut case of acanthosis nigricans, where I decided to rule out insulin resistance, and as expected, it was there. So basically, skin is not only a marker for what we see, it's much beyond what we think. And insulin resistance is something nowadays everyone is witnessing that, and we see a lot of clinical cases which, though in skin, they have a lot of implications systemically. So skin often mirrors systemic endocrine dysfunctions, and diabetes contributes significantly to individuals' health and quality of life. Skin being largest organ of the body, it is the earliest reflection of metabolic and endocrinal imbalances. And this presentation explores the skin manifestations in diabetes mellitus. Pathogenesis is hyperglycemia leading to the non-enzymatic glycosylation of collagen and hence accumulation of advanced non-degradable glycolation products, which leads to reduced acid solubility, reduces enzymatic degradation of collagen, and hence whatever the clinical manifestations of diabetes in skin we see. So basically, all the cutaneous manifestations, they have been distributed into skin manifestations that are strongly associated with diabetes, then non-specific dermatological signs and symptoms, dermatological diseases associated with diabetes, common skin infections in diabetes, cutaneous changes associated with diabetes medications. So I'll be concentrating mostly in the top 3 ones. We all know that diabetes is a latent disease with a period of around 4 to 7 years. So cutaneous manifestations can be grouped into 3 things. Number 1, they could be predictive. That means they can appear even before the diagnosis of diabetes have been made, and I have seen this a lot in my clinical practice. Number 2 is at the time of the diagnosis, at or around the time of the diagnosis, we call it as associated. Then after diagnosis as a part of complication. So skin can be an early warning sign of what is going wrong internally. Predictive markers or the early ones. Acanthosis nigricans, the story I was telling. It appears in the form of velvety hyperpigmented plaques because of hyperinsulinemia. The time gap between the occurrence of acanthosis nigricans and diabetes is roughly 2 to 5 years. There is a strong evidence of association, and 60 to 70% patients, they have insulin resistance. We should screen for diabetes mellitus too if we see such cases. Here we see velvety hyperpigmentation of intertriginous or flexural areas, or there could be the extensor area involvement also. Very easy to diagnose clinically. It is typical of what we see: thick, reticulated, hyperkeratotic, pigmented skin, mostly involving the underarms, the intimate areas, or the nape of the neck, though it can present anywhere else also. Another picture showing AN. Second is acrocordons. सब लोग आते हैं मैम बहुत सारे warts हो गए हैं. They are not warts, because they are not infectious. They are the skin outgrowth which appear as soft pedunculated papules, mostly in folds again. Again, the time period expected between diabetes and this clinical presentation is 1 to 3 years, and there is a strong evidence supporting that. And if a patient has both acanthosis as well as acrocordons, the predictive value becomes more strong. So this is another picture showing multiple growths in the skin, which is acrocordons. They can be of multiple size, they can be of variable shape, they can be of variable color too. Diagnosis phase markers, the clinical skin condition that we see in or around the diabetes. Diabetic dermatopathy. It's seen just at or around the diagnosis. We see as brown atrophic macules on the shin, commonly known as shin spots. The evidence is moderate and it indicates microangiopathy happening somewhere inside. Another case of diabetic dermatopathy on the shins. Next comes is necrobiosis lipoidica. They appear as yellow-brown plaques with telangiectasia, and the gap is up to 5 years before diagnosis. Evidence is moderate, but they are very specific for diabetes mellitus, and they are suggestive but not very sensitive for the disease. Again, another patch showing atrophic plaque over the shin, and at a red-brown rim around indicating the activity of the border. So basically there is a central clearing and the border is active. That means the disease is active. Granuloma annuli, this is a particular picture of generalized granuloma annuli where we see multiple variable size papules and they can affect any part of the body. There can be generalized body involvement also, and the evidence is weak for this disease. Early associated markers, recurrent infection. So basically we see this condition once the diagnosis has already been made and the patient suffers from more recurrent infections. We all know that, especially the fungal infection, that's candidiasis. It's because of it is visible as moist erythematous plaque and satellite papules. Time gap is from diagnosis to months or years. Evidence is moderate. Why it happens is because of hyperglycemia, hence decreased immunity. Glucose-rich environment, it favors the fungal growth. Late or complication markers. Diabetic bulla. See, this is very interesting because the difference between diabetic bulla and diabetic foot is there. Diabetic bulla is the sudden eruption of a tense bulla, which later on can become flaccid. It is a non-erythematous base. It can happen overnight also. It can settle down itself also. It generally does not require the antibiotic and it settles down over a period of 4 to 6 weeks. It happens in long-standing diabetes, though it happens rare, but it's very specific for diabetes. We all have read in our graduation days the prayer sign or the tabletop sign, which is an indicator of diabetic chiropathy, in which the thickened skin and limited joint mobility is there and we are not able to join our hands together and there is always a window or a gap between two palmar surfaces. An inability to approximate the palmar surfaces postulated to result from increased glycosylation of collagen in the skin. Generally, when we see this, there is more chances of associated retinopathy, nephropathy, and duration is important for this, not actually the control. Next is diabetic foot. It happens because of mostly the ischemia and the neuropathic factors happening together. Neuropathic ulcers on the toes of a patient with diabetic sensory neuropathy. Non-painful ulcers at the site of pressure, most commonly on the foot. Generally, it starts with the keratotic rim and there becomes a hard, firm area which later become ulcerate. Other associations are scleroderma or adultorum of Buschke, where we see diffuse thickening over the back or the neck due to glycosaminoglycans deposition, and it is seen in uncontrolled diabetes mellitus. Association is moderate. Eruptive xanthomas, though it is more commonly associated with hyperlipidemias, but there are case reports where the patient has firstly presented with eruptive xanthomas and later on they were diagnosed as the cases of diabetes mellitus. Carotenoderma, in this yellow palms are there. So basically, evidence-based interpretation is we have high sensitivity for acanthosis nigricans and recurrent infections, high specificity for necrobiasis lipoidica and diabetic bulla, but the best predictor is a combination of acanthosis nigricans, acrocordons, and obesity. Timeline summary is like we can divide it into pre-diabetic, early phase diagnosis, variable phase, and late phase. Already discussed, pre-diabetic is acanthosis nigricans and acrocordons, early is recurrent infection, late phase is foot changes. Conclusion, skin is a diagnostic window to various endocrine disorders. If we see acanthosis nigricans, multiple acrocordons, recurrent candidiasis, poor wound healing, we should not hesitate to screen for diabetes. Cutaneous markers are not merely associations but temporal indicators of evolving metabolic dysfunction, and recognizing pattern aids diagnosis. Skin often whispers before the body screams, and dermatology is not just visual, it is diagnostic. Thank you so much.
Thank you so much, ma'am. Moving on to the last section of our session today, that is a recombinant DNA semaglutide advantage. I would like to introduce none other than Dr. Somabroto Rai Chaudhary, who is consultant diabetes and endocrinology at Anandalok Hospitals and Woodlands Hospital and a faculty of Department of Endocrinology of KPC Medical College. He has many publications to his accord. Over to you, sir.
So the customary Thanksgiving should start with Anirban. Dr. Anirban has saved me of a great crisis because I had back-to-back sessions in 2 halls, and he's managed this hall so well that I won't be late there. Of course, thanks to the organizers, Dr. Supratik, Dr. Gaurav, and the disclaimer that I have been contracted by Novo Nordisk, and thank you all of you who have opted for a delayed lunch and stayed back out here. I've been contracted by Novo Nordisk for this session, but I have no direct conflict of interest with regards to the talk. The case which has been provided is a hypothetical case which has been provided by Novo Nordisk Medical. Let's look at the case. Well, don't look at the picture because the patient doesn't look like a 82 kg person. So go through the figures, not to the figure of the person. 38 years, hypertension, dyslipidemia on medication, now diagnosed with type 2 diabetes. Well, current medications are only atorvastatin and valsartan. LDL cholesterol 148. Atorvastatin has to be increased now that he is diabetic. HDL 34, TG is 240. Maybe we can choose rosuvastatin instead of atorvastatin because the TG lowering capacity is better. HbA1c is 8.9, fasting 152, BP 142/90, postprandial 228. So, why are intensive glycemic control and weight loss important for our patients? What if they move around with 300 and 400? We very often find that these patients come to us very casually and asymptomatic after a so-called corporate executive health checkup in a 5-star hospital. The heavy price of poor glycemic control in diabetes care consists of every 1 year of poor glycemic control can result in 67% increase risk of myocardial infarction, 64% risk of heart failure, and 51% risk of stroke. Well, early intensive glycemic control from the holy grail of type 2 diabetes, the UKPDS studies, well, it showed that 24% reduction in microvascular complications, 15% reduction in MI, and 13% reduction in all-cause mortality. The metabolic memory and legacy effect contribute largely to microvascular benefits in the earlier years, and in the later years also contributes to the macrovascular benefits. But if we look at weight loss, the weight loss addresses core drivers of diabetes progression, which disrupts underlying pathophysiology, promotes glycemic control, reverses or slows down disease progression, and impacts the cardiometabolic risk factor. Thereby, it can prevent micro and macrovascular complications. The key clinical criteria for an ideal first-line agent, it should have proven efficacy and safety with high level of evidence. The benefits should outweigh the risk. So it can reduce HbA1c, but it increases your body weight. So then it would contribute adversely to the pathophysiology, and so that agent would not be considered as ideal. Effective in majority of the target population, added patient convenience, provides good value for money and recommended by guidelines. So why choose semaglutide over other first-line anti-diabetic drugs? Or should I say Ozempic over other first-line anti-diabetic drugs? Let's stick to semaglutide for the time being and come to Ozempic later. So GLP-1 receptor agonists, we had met them quite few years ago when exenatide came in, and then we had liraglutide, and then we had once weekly dulaglutide, and now we have semaglutide. Before that we had oral semaglutide too. So it contributes 7 out of the 8 pathways of the ominous octet. This is an age-old slide, I won't go to read it. Comprehensive overview of the potent GLP-1 RAs, they show us that semaglutide is a human GLP-1 analog, exhibits 94% homology to endogenous GLP, and Novo Nordisk semaglutide has been extensively studied across RCTs and real-world evidences. It has a half-life of about 7 days and hence suitable for once-weekly dosing. It has been co-formulated also with SNAC, as I told you, oral semaglutide, which was available, and it thus enables oral dosing as well. These are the clinical trial programs. 1,246 Indian patients were included in SUSTAIN 8 versus canagliflozin, in SUSTAIN 7 versus dulaglutide, in SUSTAIN 4 semaglutide 1 versus 2 milligram, add on to metformin and sulfonylurea, in SUSTAIN 10, SUSTAIN 9. So total population was 20,000 in 17 trials, and of which 1,246 Indian participants were there. It reduces A1C up to 2.8% in people with high baseline A1C, proven to be superior versus other anti-diabetic agents with regards to HbA1c reduction, and also ye dil mange more, it gives you weight loss, CV benefits, kidney benefits, and is guideline endorsed. Ozempic in the studies had helped 4 out of 5 patients, up to 80% of patients with diabetes reached a guideline recommended target of less than 7% in the SUSTAIN program. It reduced body weight by up to 8 kg in people with diabetes with high baseline BMI and reduced waist circumference. So achieving weight loss in type 2 diabetes is difficult due to multiple factors, which would be perhaps discussed by my speaker later on. Ozempic helps people achieve clinically meaningful weight loss. 2 out of 3 people, up to 66% people with diabetes reached a weight loss target of at least 5% in the SUSTAIN program. So Ozempic was the trade name up to 1 and 2 milligram, but you had semaglutide in the strengths of 1.7 and also in the strength of 2.4, which was branded as Wegovy and was approved for the weight loss. Wegovy is built on the semaglutide molecule and it causes up to 18% mean weight loss with 2.4, greater than 20% weight loss in 1 out of 3 patients, and sustained weight loss over 4 years with Wegovy. Wegovy, what is the indication? Whether if your BMI is 30 and you have no complication due to obesity, still you are eligible to take Wegovy. And BMI 27 or greater, in the presence of at least one weight-related comorbid condition such as hypertension, type 2 diabetes or dyslipidemia, you are eligible to take Wegovy. Weight loss with Ozempic was predominantly driven by fat mass loss, thereby increasing overall lean mass proportion. Mean reduction in total fat mass was 10.2% and total lean mass was 4.5%. So there was a statistical tweak and it made that the mean increase in lean mass as a proportion of the whole body was 1.2%. So optimal nutrition and physical activity are essential to minimize muscle loss. Protein intake of about 1.5 kg per day, fiber 21 grams per day in women and 30 grams per day in men. Hydration 2 to 3 liters per day, it's very important. Resistance training to build, maintain and build muscle strength, and physical activity of 150 minutes of moderate intensity. Semaglutide is endorsed by ADA as a very high efficacy drug for both glucose lowering and weight lowering effects. SUSTAIN 6 was the cardiovascular trial and it compared between Ozempic 1 milligram once weekly, 0.5, placebo 1 and 0.5. Dose escalation or treatment maintenance was 96 to 100 weeks, and then there was a follow-up period of 5 weeks. Total treatment duration was 104 weeks. 83% participants had established cardiovascular disease or CKD or both. It was a randomized, double-blind, placebo-controlled multicentric trial and it produced a 26% lower reduction of the 3P MACE and in addition caused up to 12% reduction in free fatty acid level, 14% reduction in triglycerides, 12% reduction in serum very low density lipoprotein and reduction in serum LDL cholesterol by 8% also. This FLOW trial was a trial of the kidney outcomes and the primary composite outcome was greater than 50% reduction in EGFR, kidney failures, cardiovascular death or death due to kidney failure. Secondary outcomes which were assessed were annual rate of change in EGFR from randomization to end of trial, major cardiovascular events and death from any cause. And what did flow show us? There was a 24% lower risk of composite kidney outcome and proven risk of reduction of kidney events with Ozempic was 65% lower loss of kidney function, 32% lower urine ACR reduction, and proven to delay kidney failure by up to 5 years. GI side effects with Ozempic are typically mild to moderate and are transient. And if you looked at Ozempic 0.5 versus 1, mild events were very high, 87.6. So nearly, if you looked at the 145 events, moderate events were 8.3 and severe events were 4.1. Ozempic has a very convenient weekly dosing system, and you start at 0.25 for 4 weeks, 0.5 milligram for at least 4 weeks, and 1 milligram weekly for additional control for HbA1c. And although it is present abroad, 2 milligram of Ozempic is not available, but I proceed a little bit more practically. So if I go by the 8-week regime, because then we see if we start low and go slow, perhaps your body gets accustomed to the molecule and dropouts are less. With the liraglutide molecule, we have also published data regarding lower than lowest dose injectable. Ribelsus is a oral semaglutide, offers alternative dosing for people with diabetes who prefer oral drugs. Wake up, take your Ribelsus tablet straight away with half a glass of water and wait for at least 30 minutes before eating, drinking or taking other oral medication. The starting dose is 3 milligram, then next 4 weeks it's 7, and if required you can go up to 14 milligram, and 25 milligram has recently received approval for obesity purpose. So what makes Ozempic the optimal first line therapy? Powerful glucose reduction. You needed, the patient was at 8.9, so up to 2.8 was reduced. So we expect that he would come to near 6.5. Compelling weight loss. Yes, it was required. Cardiorenal protection, as because he was hypertensive and he had dyslipidemia. Dosing convenience of once weekly, and it was recommended by guideline. Follow up with our patient. Baseline weight of 82 and 3 months he was 71. Not all patients do respond like this, don't expect. HbA1c 8.9 to 7.2, fasting plasma glucose reduced, PP reduced. Very important, the total cholesterol reduced to 205, LDL reduced to 130. Still needs more reduction because, as I told you, there should have been an up-titration of the statin, which he was at atorvastatin 20, maybe a rosuvastatin 40 or atorvastatin 40 could have been tried. I do not know whether for this patient the A was up-titrated. The triglyceride was 240 and it reduced to 190, HDL 34, it had increased to 38, and BP has also reduced. Our patient, which is a common finding now, comes across alternative semaglutide brands on social media. So this is a very recent patient. So after 21st of March, he comes across and he wishes to know the key differences versus Ozempic. It is a long legacy of use and experience across the globe. Number 1 prescribed GLP-1 RA in the world, greater than 49 million person years of experience. These are all data for the patient. It would not be very interesting for you. It is the original recombinant DNA technique derived semaglutide coming from the house of Novo Nordisk, who has experience of 25 plus years in GLP-1 care. So what are biologics, biosimilars and synthetic copies? They are not all the same. Original biologics are originator or innovator molecules produced by a complex biological process, in this case by recombinant DNA technology. Biosimilars, highly similar to the innovator but may have slight differences, but also produced by the biological process. Synthetic copies are not necessarily identical to the innovator and produced by a completely chemical process, which includes all the upcoming injectable semaglutide copies that are available now. The process defines the final product when peptides are involved. The expertise in peptide chemistry ensures assured consistency, persistent quality, and proven safety. The process impacts the quality of semaglutide. This 2024 publication, which is there, had analyzed 16 samples. 16 samples of injectable semaglutide copies, 8 oral semaglutide copies, and 2 liraglutide copies manufactured via synthetic process. So, what did it come? GLP-1 synthetic copies tested versus innovator semaglutide were found to have high levels of impurities, aggregates, oxidation, instability, incorrect dose, structural changes, and contamination. So let's look at this. This is Bianca Castafiore. So she decided that she wanted to become thin and decided upon Wegovy. But we don't know whether she will become this thin or not. She cannot also decide on whether to take the originator or to take copies which are available. And this is our famous Narayan Devnath's superintendent, sir. He was diagnosed with diabetes. He chose to take Ozempic and he wished to have a figure like this when next time he goes into school. But will they achieve their goals? To look, I put the question forward to two eminent people. One is Professor Shonku and the other is Cuthbert Calculus. And they all said, well, we don't know. So, let's look at what the data says. This is a tabular comparison of A1C and weight loss impact of the genotype. So, now genes are coming into the medicine part of it, and it is determining which class of patients are going to respond with regards to HbA1c, which class of patients are going to respond with regards to weight. If it has got a GG, that is 0A allele, each G allele is associated with 0.08% higher HbA1c reduction compared with the A allele. With the GA, which has got one A allele, the HbA1c reduction is attenuated versus the other one, that's the first one. And where you have got two AA alleles, this dose effect, AA that has the smallest HbA1c reduction of the three groups because the HbA1c reduction reduces despite often the highest weight loss. So those with the highest weight loss may not have the greatest HbA1c benefit. So what are the key takeaways from this chart? The A allele is generally favorable for weight or fat mass reduction with GLP-1 RA, that is liraglutide or semaglutide, with AA leading and GG being the least. The A allele is associated with smaller HbA1c improvement across cohorts. Absolute effect sizes vary, but the direction of the effect is relatively consistent. Well, if you really look at molecular identity versus production method, the pharmacodynamic target of semaglutide is the GLP-1 receptor, and what matters biologically is the precise amino acid sequence and post-translational modification, that's the side chain acylation, not how the peptide was made. So recombinant yeast versus solid phase peptide synthesis may not be different. If a synthetic semaglutide is exactly the same as the recombinant API, then in the presence of a specific GLP-1 receptor or related gene polymorphism, its binding and intrinsic signaling should be indistinguishable. So what can change with synthetic or compounded versions? In practice, synthetic or compounded semaglutide often has different impurity profiles, truncated peptides, deletion sequences and misacylated species, altered physical stability and solubility which may affect absorption and peak time profiles. These differences can modify the exposure, potentially alter immunogenicity or side effect profile, indirectly influence how a given genetic variant manifests in terms of efficacy or GI side effects even if the receptor mutation itself is unchanged. Relevance to synthetic versus recombinant. However, this is very important, it comes from here. if the synthetic or compounded version has different pK, which usually the data shows it doesn't have, exposure, but the third thing is important, impurities. It is bound to have different impurities because it's produced by a different method. And the absolute magnitude of the weight loss benefit and GI side effect burden in the A allele carriers may differ from what is seen in trials of the approved recombinant product. This is a publication from the Nature, open access, and it is published on 8th April, just a few days ago. Well, genetic predictors of GLP-1 receptor agonist weight loss and side effects, they have identified other genes also. Perhaps we will get data in near future, and producing a molecule is not enough. The factory to the patient's door to the needle tip is important. So robust cold chain compliance is essential for Indian summers. Semaglutide, being a peptide, is temperature sensitive and requires strict 2 to 8 degree control to preserve peptide integrity and clinical potency. Ensures the originators ensure end-to-end cold chain compliance from factory to fridge. For Ozempic, the wealth of data can guide us to make informed decisions for better patient outcomes. And, well, Indian perspective for original semaglutide, available in India for about 4 years, 3,500 trial participants, and 4 lakh Indian users, available in 2 formulations now. Device is an integral part of injectable semaglutide therapy. It's just like garnishing, which is made on the food by the 5-star hotels. No push button extension, low injection force, easy to use, and confidence in drug delivery can be had with the originator. And these are the few differences, but main difference is whether the synthetics with different impurities would work as well as the originator, we don't know. If you consider HbA1c and weight, there is small amount of data that they have submitted that it is going to work as well. But you do not give semaglutide only for HbA1c and weight. You want its NASH protection, you want the cardiovascular outcome benefit, and you also want the kidney benefit. Yes, the NASH, you can use the synthetic ones. Look at 2 consistent fibroscan reports and decide. You can look at creatinines, and you can look at the urine ACR and decide about the synthetic ones. But the cardiovascular outcome, you cannot. So your patient with high cardiovascular risk and multiple risk factors deserves the best of life. So the data is still very much strong with the originator. Thank you so very much for your kind listening, and holistic care with Ozempic with convenience and used by over 28 million across the globe. Thank you. Thank you so very much. I have saved 2 minutes. Thank you, sir.
Thank you, sir. Moving on to the last topic of the day, there is newer generation insulin and promising solution to glycemic havoc in India. I'd like to invite Dr. Nirmala Roy, who is professor of Department of General Medicine, KPC Medical College, and consultant physician at BM Birla Heart Research. Over to you, sir.
How do I change the slides? Is it ready?
Yes.
Okay. Thank you very much. At the outset, let me express my sincere gratitude to Dr. Supratik and other organizers for having given me this opportunity. I also express my gratitude to Novo Nordisk for sponsoring this talk. Well, after a long time, ever since the semaglutide and tirzepatide days have started, I have been talking only about tirzepatide and semaglutide. I'm also very happy because after a long time I'm returning back to speaking on insulin. I express my deep gratitude for all the people who stayed back to listen to this talk, particularly when a sumptuous lunch is waiting for them. Thank you very much for listening. Well, whether you hate diabetes or whether you love diabetes, you just can't ignore diabetes. Nothing is as much true as about insulin. Insulin is here to stay, despite the fact that the knowledge about, the noise surrounding insulin has gone down. But unfortunately, people need to come to terms that there is no replacement for insulin. Indeed, GLP-1 agonists were discovered before insulin was invented, but then it took a back seat because insulin pushed it down because of its large-scale efficacy. But now things have changed a little bit. These are strange days. Novo, a traditional insulin making company, is trying to sell oral drugs, talking about obesity. Wonderful thing, but then we cannot write off insulin so easily. ICMR IndiDiab statistics are quite dismal. They talk about prevalence of diabetes close to 11 to 15% in Indian subcontinent, 11% for full-blown diabetes and 15% for pre-diabetes, which is quite a big number. India is a strange country. We always talk like, where will you get one plate of biryani which weighs more than another plate of biryani weighing maybe with bigger pieces of meat? We do not have any fixed serving size. What I call chapati in my home, my Punjabi neighbor has a different connotation for chapati in his home. So we do not have any serving size, no knowledge of serving size. The same food bearing the same name will have different connotations at different home. Food changes from home kitchen to kitchen. So high carbohydrate diet is something of a truth in India. 64% of our energy comes from the carbohydrate. Well, honestly speaking, very few people take to exercise. One thing which has happened well with the days of Ozempic is that people have become more of health conscious. All the people whom I saw earlier as plump human beings now are steadily losing weight, but not thanks to diet and exercise, but more to the Ozempic days. Only 1 in 3 people follow the advice regarding exercise, and only 1 in 2 people are compliant with diet. Honestly speaking, food is an important cultural parameter in India. We need to understand that when we are at conference, when we are at a marriage, when we are at a meeting, the only thing which concerns us most is the food. So if your diet cannot be controlled well with Ozempic, then you have to make do with insulin. And believe me, with insulin, Ozempic is also a very reasonable companion. Glycemic response. In fact, we always believe the Monniers hypothesis, that is the fix fasting first. But in South Asians, with lot of papers emanating from Southeast Asian countries and China, we know that postprandial glucose peaks that are 2 to 3 times higher than in Caucasians who may be eating a meat sandwich with little bit of maybe salad. PPG is a unique challenge and the consequences are immense in this subcontinent. Some 83% of the adults with type 2 diabetes in India have suboptimal PPG control. Consequences of uncontrolled PPG, well, we have always known that PPG is an independent risk factor for cardiovascular disease. Increased PPG and FPG drive the increase in HbA1c in India. Increased PPG has been found to be closely associated with microvascular complications as against many of the Western studies. Inadequate control with first generation insulin is a reality. only 30% of the patients achieve a target HbA1c within 6 months post-initiation with basal insulin glargine, which I must say had been a game changer. So, but in reality, we need to understand certain things better, that we are treating patients in India, and therefore 64% of the patients achieving FPG of less than 100 achieve HbA1c of less than 7%. On the contrary, when people achieve the PPG target of less than 140, the HbA1c is more likely to be achieved to the of less than 7% to the tune of 94%. So aim of a good control should be taking care of both fasting, the PP, in order to bring the HbA1c down to control. So what are the aid for total control? Well, one of the game changers had been Rhizodeg, the IDEG ASP, as it is scientifically known as. It is a unique product because it's a co-formulation. All of you must know that when it comes to using premixed insulin, one of the biggest challenge is the ritual which is associated with the premixed insulin, which patients very often tend to forget. Not only the patients, in my practice, I have seen even the doctors are often not quite aware of the rituals that one has to follow while using a premixed insulin, that is the resuspension. Many people will do the resuspension most carelessly. How many people actually know that they have to do a resuspension around 10 to 15 times before you actually inject the insulin? Another bigger problem is that those human premixed insulin that we use, they need to be dosed around 20 minutes. 20 minutes is a big time. People either eat soon after injecting, or they simply forget to eat within 20 minutes of after 20 minutes of injection, leading to either hypoglycemia or poor control. So these are very practical problems. Moreover, whenever we tell patients to take insulin twice daily, they always bargain with us to take it once daily. So insulin co-formulation is unique in the way that both the long-acting insulin degludec and short-acting insulin aspart, they exist in good harmony, and there is no resuspension is needed. Say for example, somebody wants to eat a sumptuous lunch today, and then tomorrow he wants a sumptuous dinner, he can simply dose it before lunch today and tomorrow before dinner, as long as he is not dosing it within 8 hours and not going beyond 40 hours. But certainly I will not encourage him to do that. Insulin IDEG ASP has, as I said, is a unique formulation. It has got degludec and aspart existing separately. Degludec exists as dihexamer and aspart as hexamer, and when the injection is given, the zinc diffuses out and aspart is quickly brought into action by being in the circulation. So key attributes are not only the convenience, but efficacy, safety, quality of life and flexibility. We need to understand just being efficacious and safe are not enough. Patients should enjoy taking it and should be given flexibility. SMART study went on to show that IDEG ASP showed effective control of HbA1c overall, 1.7% reduction, be it OAD treated or be it other insulin treated. Significant improvement in fasting to the tune of 50, and significant reduction of PPG to the tune of 82 have been noted in SMART study. One of the biggest deterrent of insulin use is the fear of hypoglycemia. So hypoglycemia is quite insignificant when it comes to IDEG ASP, because the confirmed hypoglycemia, as we see, are quite less with IDEG ASP, and severe hypoglycemia, the nocturnal hypoglycemia, they are also quite low. We need to understand certain other things, the issue of the quality of life. Most patients reported a questionnaire-based quality of life improvement of 89%, found Rhizodeg quite comfortable, and manage their day-to-day activities. Remember, this is not a 5-day treatment. It is a treatment which goes on for, indefinitely. Improved quality of life has been associated with changing of from other insulin to insulin IDEG ASP. Higher patient preference, as I have said, with 78.8% continued treatment. One of the biggest deterrent in insulin therapy is the rate of discontinuation. Most people would choose to discontinue after achieving control. It is largely driven by inconvenience, and when it comes to IDEGAS, most people would choose to continue. As I said, it is a big chunk of Indian young people, they work in shifts, and it is extremely difficult when it comes to taking insulin for them. For such patients, IDEG ASP is a welcome change. We need to understand further when we dose these start this insulin, remember 3 important saying: start low, go slow. The second important thing, make the patient aware of hypoglycemia, and should you have sulfonylurea in place, use it only with basal insulin. Do not use them when the prandial insulin is on board. However, IDEG ASP can be used with a little dose of sulfonylurea. Initiate with 10 units of IDEG ASP just before the most carbohydrate heavy meal of the day, and then simply go up titrating as per a very simple algorithm, that is the average of the 3 fasting readings by 2 units if you want a simple solution. Remember, a single episode of hypoglycemia can be quite scary. Large proportion of people in India stay alone, and particularly in the metro cities, it has been found that for elderly people staying alone, this is quite a good insulin. It can be used safely in patients with renal and hepatic impairment. Mind you, it can be used safely with hepatic and renal impairment, particularly because of the fact that degludec binds with albumin, and it has been shown that there is not much alteration in the pharmacokinetics. Well, Ramadan is the time when 1/3 of the world is observing the fast, and it is essential that we tailor-made insulin practice for these months. It is a good practice to dose IDEG ASP just prior to iftar in such cases. Well, in type 1 diabetes, I will not quite venture to use IDEG ASP in type 1 diabetes, but I do use degludec lot of times in type 1 diabetes, and safety has been recorded. So IDEG ASP is basically effective FPG and PPG, lower risk of hypoglycemia, more people achieving target, and happier patients. Now, when it comes to newer generation basal insulin, we talk more of, IDEG ASP, as I have said. There is no watershed beyond which the newer generations start, but since it's a novo talk, they didn't want me to talk about the glargine U300, a little bit about glargine U300 as well. Glargine U300 will give you a latitude of 4 hours when it comes to taking the insulin at the time of at the same time. Like glargine U100 you have to take at the fixed time, but glargine U300 gives you a latitude of 4 hours. However, the degludec gives you a latitude of 8 to 40 hours, right? So that makes it more convenient. Another important thing is the shorter rapid acting insulin, the insulin aspart. When insulin fast acting aspart, as is known as FIASP, has also been a game changer. So also Tresiba, which has a flat profile and showing much less hypoglycemia, severe hypoglycemia, and nocturnal hypoglycemia. When it comes to eating, one of the biggest challenge that we face is that patients often forget to eat soon after taking insulin, and this is a problem which has been solved with fast acting aspart. When you're dosing insulin in a busy hospital, oftentimes it happens that patient been given the insulin and somebody comes and says that the radiologist is here, so patient is pushed to the radiology USG department, and lo behold, the patient ends up with hypoglycemia. So one of the best insulin to use in the hospital practice is fast acting aspart, because it can be dosed after food within 20 minutes, which is a very good window. Another important problem that we face in elderly people, that despite the fact that I have given the insulin, the patient will not eat the full meal. So if the nurse reports to you that the patient ate 50% of the meal, you can simply dose it after eating with 50% of fast-acting aspart. It is a wonderful insulin in the form that it causes much less hypoglycemia and your targets are much better achieved. Convenient dosing, because as I have said, it can be dosed before 2 minutes to at least 20 minutes after you finish the meal. So say for example, if you eat a good food in the restaurant and choose to come back within 20 minutes, you can do it at home. So all these three insulins, greater A1C reduction, target achievement, and lower risk of overall hypoglycemia and with less glycemic variability, wider window and flexibility and quality of life. Well, since it's a Novo talk, again, I'll just summarize for the brevity of the talk that there are two other newer preparations which is called fast-acting Lispro, which is a combination of a prostaglandin, treprostinil and citrate. Treprostinil is a vasodilator and citrate increases the absorption. The biggest challenge with this insulin is that it has got more of local skin site reactions. Moreover, in asthma patient, it may not be very safe to use these fast-acting Lispro, given the fact that it is laden with little bit of prostaglandin. It does not cause asthma, but those having asthma may have adverse outcome. As against fast-acting aspart, which has niacinamide and L-arginine. Another very important thing which people talk to me nowadays is with how good is Afreeza, that is the inhaled human insulin. It comes in Technosphere. It comes with a small inhalational device. 4, 8 and 12 are the 3 aliquots that you can use. But mind you, you cannot use them in patients with COPD, patients with asthma, or patients who choose to smoke quite often, because this insulin over time has been shown to cause some FEV1 reduction. Moreover, I do not find them very safe because absorption is often unpredictable. So people generally ask me, when do you use it? Well, first of all, I don't quite choose to use it, but if a patient who's on small dose of basal bolus insulin tells me that maybe I'm going for a marriage and I don't want to take the insulin in the party, then I would tell him to take 4, 8 or 12 as the case may be by inhalation. But at the same time, being very, very careful that patient is taking his or her basal insulin quite properly. It comes in a technology which is called Technosphere, and there is a carrier which has a very big tongue twister name like snack, which is called FDKP. And finally, to end the talk, a word about Icodec. The Icodec is an insulin which is on its way to come, and I understand once it comes, things will be again quite a good time for insulin patients, but there are certain things which we should remember, that sometimes it will be very difficult to convince that somebody who's taking maybe 10 units of degludec daily, that you suddenly take 70 units once a week. So that is quite a difficult thing and will have to be dealt with. Last of all, there are fixed dose combination of GLP as well as basal insulin. Novo had one by the name of Zultofi. Sanofi has one by the name of Soliqua. They never became quite popular because Sanofi uses glargine with lixisenatide. Of all the GLP-1 agonists, lixisenatide has the least amount of evidence based. So thank you very much for patient hearing and for staying back, choosing to delay your lunch for this patient hearing. Thank you once again. I work with this beautiful team. So over for the session. I don't think people are ready to ask questions.
So all must be hungry already. Thank you very much for attending the session. This was the last session, so you can proceed to the metabolic hall after the lunch. Thank you. Thank you, sir. And thanks to the team of RX Events and everyone in the back end.